Audible? Yeah, good morning, everybody, and welcome to this symposium and the Young Investigators Award by Dr. Cherian. As you know, that Dr. Cherian started this award when we started the society to encourage the young investigators and researchers in this field. I request the first presenter, Dr. Murtaza Kamal. Not this?
They've given you a wrong one.
Wrong thing, sorry.
Speed this up. I'm sorry.
Sorry for that. The first presenter is Dr. Naya Banerjee, early weight trends after congenital heart surgery and their determinants.
A very good morning to all my respected teachers, colleagues and friends. I am Dr. Naya Banerjee, DM resident. A very good morning to all my respected teachers, colleagues and friends. I am Dr. Naya Banerjee, DM resident, Department of Pediatric Cardiology in Amrita Institute of Medical Sciences, and I'll be presenting the early weight gain trends after congenital heart surgery and the determinants. So we all know that congenital heart disease increases the likelihood and severity of malnutrition. Early weight trends after cardiac surgery in infants from low and middle income countries has not been defined. Factors that determine the early nutritional recovery have also not been adequately studied in the context of cardiac surgery. Identification of correctable factors will enable the better nutritional recovery after congenital heart surgery. Keeping this in mind, the objectives of the study were to determine the trends of weight gain in the early postoperative period after cardiac surgery in infants, as well as to identify the specific factors which were associated with poor weight gain. So it was a prospective observational study for a period of 1 year from January 2018 to 2019. All infants diagnosed with congenital heart disease and undergoing cardiac surgery were included in the study. Those with in-hospital mortality and the parents who denied consent were excluded from the study. Routine demographic as well as baseline anthropometric variables were taken into consideration. Preoperative variables which included associated genetic abnormalities, any comorbidities, preoperative sepsis, ventilation, ICU stay, prostaglandin infusion, the type of surgery like palliative or corrective, and their risk stratification based on the RAX1 score were also taken into account. Intraoperative variables included cardiopulmonary bypass time, aortic cross-clamp time, re-exploration, and delayed sternal closure. Postoperative factors included the duration of both mechanical and non-invasive ventilation, postoperative sepsis, any need for resuscitation, and reintubation. Feeding patterns included the time of initiation of feeds, time to achieve the full feeds, and cumulative NPO duration. As there were no previous studies available in literature, we conducted a pilot study, and based on the result of the pilot study, the sample size was estimated to 140. So we collected 192 cases. We had 2 in-hospital mortality which were excluded, and 184 patients came off a first review, that is 1 month after follow-up, 1 month after discharge. 8 patients were lost to follow-up. Routine statistical methods were applied for the analysis. Now coming to the results, the median age of presentation was around 90 days. Most of the babies had a baseline undernutrition as evidenced by the Z-score of minus 2.54. About 22% were low birth weight babies and 17% were preterm. As you can see, most of the patients, about 38%, belong to lower middle class according to the modified socio-Kupusami scale. Coming to the preoperative variables, there was a 5% incidence of preoperative sepsis, 14% needed ventilation, 42% had a preoperative ICU stay, and 13% needed prostaglandin infusion. Most of the surgeries belong to RAX2 category, followed by RAX4 and RAX3 respectively. About 13% of the surgeries were palliative in nature, and remaining 87% were corrective surgeries. Now coming to the intraoperative variables, the median cardiopulmonary bypass time was 113 minutes, and 6% cases had delayed sternal closure. And 6% cases had delayed sternal closure. The incidence of postoperative sepsis was around close to 10%, with reintubation rate of around 14%. And median duration of postoperative ICU stay was around 92 hours. The same median duration of cumulative NPO duration was around 21 hours. So as we see the weight, we can see that there was a decline in weight initially from admission till discharge, and subsequently the babies have gained weight till first follow-up. And we see that the difference in weight, that is the weight loss initially from admission to discharge, and the subsequent weight gain from discharge to follow-up, both were considered statistically significant. So this is the graph which can represents the same thing, that the babies have lost weight initially from admission, after extubation in the post-operative ICU, till the patients come to ward, and subsequently the babies start gaining weight till discharge and at first follow-up. And both the weight loss and the subsequent weight gain were statistically significant. And this trend was reflected uniformly across all the RACS categories. So coming to the analysis, we calculated the percentage change in weight between admission and discharge and from discharge to first follow-up. And we dichotomized the babies into two groups. Those with percentage change in weight less than mean minus 1 standard deviation were categorized having poor weight gain, and those with more than mean minus 1 standard deviation as good weight gain. And we calculated them on the univariable analysis to determine the factors which were associated with poor weight gain. Those factors which came out to be significant in the unified analysis, we plotted them in the multivariate logistic regression. So this is the chart that shows the factors which came to be significant in the univariable analysis. And this table also shows the same variables, that a lot of variables came out to be positive as regards to the initial weight loss and subsequent weight gain. But if we consider the weight gain from admission to first follow-up, only two factors came to be positive, cross-clamp time and postoperative sepsis. So when you put all these factors in the multivariable regression model, we saw that the regression results for weight loss from admission to discharge, the cumulative NPO duration of more than 21 hours, which is the mean value, at an odds ratio of 10.2 with a p-value of 0.02. Similarly, cardiopulmonary bypass time more than 113 minutes at an odds ratio of 9.3 with a p-value of 0.03. The regression result of weight gain from discharge to follow-up, as on expected lines, we can see that all the neonates with age less than 1 month had a greater increase in weight gain with odds ratio of 16.5, which may be reflective of the early neonatal growth. So to conclude, we can say that weight loss is common and almost universal early after congenital heart surgery and is associated with complex surgery and cumulative NPO duration. Cumulative NPO duration resulting from feeding interruptions in the early postoperative period was probably the only apparently correctable factor which can be associated with early weight loss after surgery. After discharge, weight gain is almost universal and is not associated with any of the perioperative variables, suggesting that correction of the underlying defect leads to significant early catch-up growth. We had certain limitations. It was a single-center study, and admission and discharge times were not fixed relative to surgical intervention. And before I conclude, I would like to thank Krishna Kumar sir for his inspiration and guidance throughout the project, Rakhi madam for her meticulous inputs, our surgeons Sunil sir and Brijesh sir, and Abhish, our research coordinator and statistician, for computing the data, our social workers, Steffi and Rinku, for their help in communicating with the patients, and not to mention the entire nursing division in the pediatric cardiac ICU who had worked tirelessly for the period. Thank you for your kind attention.
Very nice presentation, Dr. Banerjee. I have a question. Did you standardize your post-discharge feeding patterns, or did you have a feeding education? Did you have gavach feeding for patients who didn't feed? How did you ensure that they were getting adequate nutrition?
Actually, sir, when the babies were being shifted to ward, after that itself, most of the babies were being breastfed. So, and on top of that, sometimes the mother was giving added top-up feed. So we cannot control the amount of feeding, but we told the mothers regarding the importance of feeding in the post-operative period once they come to the ward itself.
Now, regarding the weight loss of immediately after surgery, how many of your children were edematous, with the resultant edema passing out in the diuresis resulting in weight loss? Did you have a look at that?
Sir, actually, when we went through the data, we found that about more than 90% of the patients who had shunt lesions were already on diuretics prior to admission. So it is highly unlikely that the use of diuretics in the period would have resulted in significant weight loss. And also regarding the patients who had like VSDPS physiology, having spells, there was very few incidents of having these babies who had CFS spells regarding multiple volume overload. So we did take into consideration, but what we have found, so probably that not have mattered in our final analysis.
Did you check the pre-operative nutritional status and the feeding patterns and try to stabilize them prior to surgery? in any of your patients?
Ma'am, most of the babies we can see, we have checked into account and we have seen that most of them, close to around 60% of them were exclusively breastfed. And a larger section, around 30% were neonates. So most of them, like the transpositions and the TGAs, came straight after prenatal diagnosis directly to the ICU. So and the amount of breastfeeding the mothers could not quantify, but irrespective of the type of lesions and the RACS categories, we found that all the patients had a baseline undernutrition, irrespective of the feeding practices and the type of surgical lesions.
Are you continuing the follow-up? Because 1 month is hardly any time for growth and development.
Yes, sir. We are actually continuing the follow-up. We have instituted a protocol now after 6 months to come for the follow-up. Previously, we have reported studies on VHD closure and seen the long-term follow-up in patients, but this will reflect across all the surgical categories. So our next follow-up is at 6 months and will continue then after 1 year, yearly one-time follow-up.
Yeah, thank you, Dr. Banerjee.
Thank you so much, ma'am.
So the next presenter is Dr. Javed Raja, and he would be presenting anomalous origin of one pulmonary artery from aorta, outcome of patients who underwent direct reimplantation.
Till the presentation is being set up, we have a quick announcement to make. The plenary session for today will end by 1:30 p.m., after which we break for lunch. The scientific sessions thereafter will be held separately for the 3 specialties of cardiology, surgery, and anesthesia within this area. Scientific program for cardiology will continue in this auditorium, Dr. C. Rajeshwari Auditorium. Scientific program for surgery will be held in the Dr. P.K. Sen Hall, and anesthesia and intensive care sessions will be held in Dr. Dolly D. Hansen Hall. Over to you.
Good morning, everyone. I am here to present our institutional experience of one of a rare cardiac condition, anomalous origin of one pulmonary artery branch from the aorta and its outcomes. This condition is characterized by origin of one pulmonary artery branch from the ascending aorta. This condition is characterized by origin of one pulmonary artery branch from the ascending aorta, whereas the other pulmonary artery branch arises from the right ventricular outflow tract with two separate semilunar valves. So this is a rare condition with an incidence of less than 0.1%, and previously used to be called as hemitruncus. Actually, it's a misnomer. There is nothing to do with truncus. To call it as a truncus, there has to be only a single semilunar valve, but this condition normally has two semilunar valves. Morphologically, it is classified into proximal as well as distal based on the site of origin of the anomalous pulmonary artery. When it is close to the aorta, within 1 to 2 centimeters of the aortic valve, it is said to be proximal, and when it is distal near the origin of the innominate, it is said to be distal. Short embryology, the most commonly accepted theory is that abnormal migration of the neural crest cells, which play an important role in the development of the conotruncal ridges, is the accepted theory for this condition. The other theories include incomplete migration of the right sixth aortic arch, as well as failure of development of the left sixth aortic arch, leading to failure of fusion of the LPA to MPA. Coming to the pathophysiology, this condition is a bit unique. Though the anomalous pulmonary artery supplies one lung, there will be development of pulmonary vascular disease in both the lungs. So the lung with a normally arising PA is also exposed to volume overload because the entire right ventricle output has to go to a single lung. Whereas the lung with anomalous pulmonary artery is exposed to both the pressure as well as volume overload, thereby leading to increased pulmonary blood flow in left ventricular failure, as well as early development of pulmonary artery hypertension because of circulating vasoconstrictors, as well as neurogenic crossovers from the unprotected lung. So the objectives of our study is to assess the outcome of children who underwent direct reimplantation of this anomalous pulmonary artery to the main pulmonary artery, as well as to assess the symptomatic states, mean PA pressures, and anastomotic gradient in the follow-up period. So this is a retrospective study carried out in our center. All the children who were diagnosed with anomalous pulmonary artery were retrospectively analyzed, and the data are collected from January 2000 to December 2018. There were total 11 children who were diagnosed and 9 children who were operated. All children presented with congestive heart failure. All children underwent direct reimplantation of the anomalous pulmonary artery. Operative technique after standard high ascending aortic cannulation and bicaval cannulation, immediately the anomalous pulmonary artery will be snared, PDA will be ligated and divided. Mild hypothermic cardioplegic arrest was used in 7 patients. The other 2 patients which we operated were done without cardioplegic arrest. So what we did was the aorta was transected just above the origin of the anomalous pulmonary artery, followed by which the anomalous pulmonary artery is harvested along with the cuff of the posterior wall of the aorta, and then an incision is made on the lateral aspect of MPA, and direct anastomosis, direct reimplantation of the anomalous pulmonary artery to the MPA will be done, followed by end-to-end anastomosis of the transected aortic ends. So the other 2 patients underwent surgical repair without cardioplegic arrest, in which a side-biting clamp was used on the ascending aorta and the anomalous PA was harvested, following which the direct closure of the defect in the aorta was done, and then direct reimplantation of the anomalous PA to the main pulmonary artery was done. PA pressures were monitored in all patients post-operatively. Coming to the results, so the median age of the children who were operated was 6 months, ranging from 15 days to 28 years. Majority of them were less than 1 year, only 3 kids were above 1 year. More common in females. Coming to the weight, the median weight was 5.7 kg, with the smallest weight being 1.8 kg, and the largest presented with was 40 kg. The anomalous RPA was more common than the LPA. 8 kids were diagnosed with anomalous RPA, and the most commonly associated anomaly was PDA, seen in 7 kids, and TOF was seen in 3 kids, and subaortic membrane in 1. Median cross-clamp time was 78 minutes. Median CPB time was 129 minutes. Patients 1 and 3 did not have the cardioplegia. So and 7 and 10 patients were not operated. Median ICU stay of the patients was 5.5 days, and median ventilation time was 31 hours. 2 children presented late, and we couldn't operate them because they had already developed irreversible pulmonary vascular disease. Coming to the post-operative complication, there was 1 mortality in our series. The child died in the immediate postoperative period because of severe RV dysfunction and sepsis. 2 kids had developed PA crisis, which were managed medically, and 1 kid has surgical site infection, which was treated with antibiotics. And all these 8 kids are on regular follow-up. The follow-up period ranges from 12 to 78 months. You can see all the children were followed up and they were assessed using modified raw score. The score was, all the children had a score of less than 2. And you can see the yellow line showing the anastomotic gradient. All the children had a gradient less than 30. And all children had an RVSP also of less than 20. Coming to discussion, so this condition is discussed because number one, it is rare. It has an incidence of only 0.1%. And the second one is there is a paucity of literature. Only very few case series have come throughout the world. The biggest case series from India was from All India Institute of Medical Sciences from Dr. Sachin Talwar sir. And the third one is the complexity in the management, especially the preoperative management of these kids. Usually these kids present with congestive cardiac failure in the preoperative stage. They need decongestive measures and sometimes they need elective ventilation in the preoperative period. So once they put on ventilator, it is very difficult to manage the ventilator settings, especially in the preoperative period. So the optimal, the ventilator setting should be optimal such that it should neither hyperventilate nor hypoventilate. So if you hyperventilate, then RV dysfunction will set in. If you hypoventilate, again, LV dysfunction. So I want to just show the 2 images here. This is the condition, a hemitruncus, and you can see normally presents with LV volume overload, but it can also present with RV volume overload. So to summarize, aortic anomalous origin of pulmonary artery is a potentially treatable lesion with acceptable long-term outcomes and near normal quality of life if operated in early infancy. And direct pulmonary implantation is the preferred surgical strategy which we follow as it has provided good results. Thank you.
Thank you for your presentation. 2 quick questions. One, the patient who was 28 years old, how was he still operable?
No, sir, we did a cardiac catheterization and we found that this patient was not operable. So we didn't, the patient itself presented only at 25 years of age to our OPD.
So he's one of the unoperated patients?
Yeah, one of the unoperated patients, sir.
Okay. Second question, did you try to do any of these patients without cardiopulmonary bypass? Because it's
no, sir, all the patients were put on cardiopulmonary bypass.
It is quite possible to do these cases.
Yeah, it can be done, sir, without cardiopulmonary bypass also.
But you didn't attempt.
We didn't try, sir.
Thank you.
So the 5 cases that had pulmonary hypertension post-op, how did you manage that?
So normally, sir, for all patients preoperatively, if they are diagnosed with severe pulmonary hypertension, we normally give intravenous sildenafil in the postoperative period for 48 to 62 hours at a dose of 1.6 mg per kg per day, followed by which we will switch over to oral sildenafil for the next 3 to 6 months, sir. 2 patients had PA crisis, so that 2 children were ventilated for 72 hours, and after that, PA pressures came down, and then we were able to extubate, sir.
Do you continue this post-op also?
Which one, sir?
The sildenafil?
Yeah, we'll continue in the postoperative period for 48 to 72 hours, sir. IV sildenafil infusion.
And what did you make any change in your perfusion strategy?
Perfusion strategies. We normally till the dissection part, everything is over. We keep the perfusate warm so that the LV doesn't get distended, and we immediately snare the pulmonary artery once we go on bypass, and PDA will also be tackled immediately, so to prevent LV volume overload, and we'll also put a vent immediately, sir.
Did you filter these patients? Ultrafiltration? Do you modify ultrafiltration?
We do a modified ultrafiltration for all PAH patients, sir.
The patient who persisted to be in pulmonary hypertension, did they have pre-op cardiac catheterization in any of your patients?
No, ma'am. Actually, only the 2 patients which presented late had a cardiac catheterization. So we couldn't.
I have one question for you. What's the conclusion? I mean, you've had a concluding slide, but what message does your study actually have to convey so that
yes,
we can learn from your experience?
Sir, this is a rare condition. So the limitation of our study is mainly the number of patients, only 10 patients for the past 20 years. So though it is a rare condition, there is high chances this condition can develop PAH very early. So the kid we lost was presented to us at 15 months of age. So when we operated, child had a severe RV dysfunction in the post-operative period, and we couldn't salvage the child. So the idea is that as soon as the diagnosis is made, anomalous pulmonary artery, so we have to go and operate. That's the message we are giving, sir.
The curtain has come at a perfect timing. Thank you.
Be presenting on ivabradine versus
Good morning, everyone. Myself, Dr. Arvind. I am a DM senior resident in Pediatric Cardiology from All India Institute of Medical Sciences, New Delhi. At the outset, I would like to thank the organizing team for giving the opportunity to present the award session. And it's a great privilege and honor to be presenting in front of the jury the results of my study. My study is a randomized control trial which compared ivabradine and amiodarone for the management of postoperative junctional ectopic tachycardia in children. So as we know, JET is a common postoperative arrhythmia in children after cardiac surgery, and wide range of incidents has been reported from various cardiac units. As far as pharmacotherapy is concerned, amiodarone has been the preferred drug in management of JET, but recently there have been reports of successful usage of ivabradine in JET. So we hypothesize that ivabradine is not inferior to amiodarone in converting postoperative JET to sinus rhythm in patients less than 18 years of age undergoing elective open heart surgery. Restoration of normal sinus rhythm was my primary outcome. Time taken to achieve normal sinus rhythm, heart rate control to age acceptable levels, and time taken to achieve this heart rate control were my secondary outcomes. So we designed it as a open labeled RCT. We adopted a non-inferiority trial design, and the study was conducted in Department of Cardiology and CTVS AIMS New Delhi after Institute Ethics Committee approval and registering with the CTRI. Patients less than 18 years of age who developed JET after elective open heart surgery were included in the study. Those patients who were already on antiarrhythmic drugs, patients who underwent emergency surgery, and patients with features of multi-organ dysfunction were excluded. We diagnosed JET based on surface electrocardiograms which showed AV dissociation with a ventricular rate more than atrial rate, and the ventricular rate was more than 95th percentile for age. We followed a block randomization sequence with variable block sizes, and the allocation was concealed using the use of opaque sealed envelopes. Those who were randomized to the amiodarone were started on intravenous amiodarone in the mentioned doses, whereas those in the ivabradine arm were started with oral or nasogastric ivabradine at 0.2 milligram per kg per day in 2 divided doses. After 24 hours of the first ivabradine dose, if sinus rhythm is not achieved in these patients, the dose would be either escalated to 0.4 milligram per day, or it would be switched over to amiodarone, or the ivabradine would be continued with the same dose. This decision would be taken depending on the general clinical condition of the child and in consensus with the cardiac intensivist, who is the primary treating physician. So all patients were admitted in the CSICUs and monitored using multi-monitors which had the memory to save the data trend for at least 48 hours, and blood gases and blood parameters were done as per the unit's existing protocol. So coming on to the results, till now we have randomized 70 patients, 32 in the amiodarone arm and 38 in the ivabradine arm. Apart from greater proportion of boys in the ivabradine arm, other baseline characters such as age, weight, height, the cardiopulmonary bypass time, aortic cross-clamp time, and time from surgery to onset of tachyarrhythmia, and numbers in whom right ventriculotomy was performed was comparable between both the groups. So as for As far as the underlying cardiac defects is concerned, TOF constituted the majority, followed by VSD, DCRV, and other cardiac pathologies as shown. And all were biventricular repairs, and we did not include univentricular repairs in this study. So the primary outcome parameter, which was conversion to sinus rhythm, was achieved in 97% of patients in the amiodarone arm and 94.7% in the ivabradine arm. That is, 2 patients of the 38 in the ivabradine arm did not revert to sinus rhythm. And also, the time taken to achieve sinus rhythm was longer with the ivabradine group, which was 28.5 hours, though statistically non-significant. When we compared the mean difference in primary outcome between these two groups, it was minus 2.1%. However, the confidence interval was just touching the non-inferiority margin of minus 10%. Heart rate control was achieved in all the patients in both the arms, both the intervention arms. However, the time to heart rate control was faster, significantly faster with amiodarone, which was 7 hours and 9.4 hours in the ivabradine arm. So, it is well established that inotropes, reduction in the dose of inotropes can also lead to reversal of arrhythmia. So, we tried to remove this confounding effect. We did this by calculating vasotropic inotropic scores, which are established in this age group as a method to quantify the inotropic dose in these patients. We quantified this at 3 time points during the study: when the arrhythmia started, when heart rate was controlled, and when sinus rhythm was achieved. And we compared these scores between the two groups, and we found that the scores were not different. And also, the difference in change of scores between these 2 points was also similar between the groups. So the other observation was the recurrence of jet was more with the ivabradine arm. There were 6 patients in whom the arrhythmia recurred after stopping of the drug, requiring to restart the drug or prolong the therapy. And there was 2 mortality in the ivabradine arm, though it was non-cardiac. Both were related to sepsis. So the largest published series available is a retrospective review of 8 patients from Amrita Institute, Kochi. It used ivabradine at 0.05 milligram per kg per dose, which is half the dose which we had used, and most of the patients responded similar to in our group even. The strength of the study is, this is the largest and the first contemporary RCT in this subject using a rigorous study methodology. And a novel indication for ivabradine has been systematically demonstrated. The greatest limitation is that the oral drug we had compared with the intravenous drug, just because the intravenous formulation of ivabradine is not available in the country as of yet. And to conclude, ivabradine was not shown to be non-inferior to amiodarone. However, it resulted in conversion of postoperative jet in almost 95% of patients. Ivabradine took longer to achieve sinus rhythm and to achieve heart rate control. Ivabradine doses up to 0.4 mg per kg per day were tolerated without any major adverse events. And the ease of administration was there with ivabradine, and it is considered as it can be considered as a favorable alternative to amiodarone.
Thank you, Dr. Balaji. Very nice presentation. 2 questions. Jet can be acutely hemodynamically destabilizing in the postoperative patient. So, were there any adjunctive measures that you used, which would normally be used, which would be basically withdrawal of epinephrine as a catecholamine and core cooling? Were the adjunctive measures used while you were also administering?
All the patients at the onset of arrhythmia were instituted on general measures, which included temperature control, optimizing the sedation and ventilation, and trying to taper the inotropes as hemodynamically if it is possible. If the arrhythmia persisted even after 30 minutes of the onset, then only we try to, if after optimizing all this therapy also, if the arrhythmia is persistent only, we considered pharmacotherapy.
And was there any attempt to switch over? Like if a patient was recruited for ivabradine, if he was hemodynamically very unstable, did you switch over to
Yes, sir.
amiodarone because it would be faster acting? So was there any crossover?
Yes, sir. In 2 patients who did not revert with ivabradine, one of the patient was hemodynamically worsening, so we had to switch over to amiodarone very early in the course. It was around before 24 hours of the drug. And the other patient was hemodynamically stable, but after switching out to amiodarone, he reverted after 36 hours of starting amiodarone. But he was not hemodynamically crashing or so. But
Thank you.
So did you, you can have jet without much of hemodynamic compromise also. So did you treat only those which were hemodynamically compromised, or every jet you treated with this?
no, sir, we did not wait for hemodynamic compromise. If the arrhythmia has been persisting, we even after institution of general measures, we started on pharmacotherapy. We did not treat only those arrhythmias which causing hemodynamic disturbance. We didn't wait till the hemodynamic.
And what was the commonest lesion which you corrected and there was jet here?
Sir, sorry?
What was the commonest lesion? Tetralogy?
Tetralogy of fallow constituted more than 80% in our study group. Of the 70 patients, more than 80% were tetralogy.
Did you find any difference between these?
Sir, no, I didn't analyze in that this thing.
Now, has it changed your practice that you start ivabradine as a first drug of choice in your ICUs?
Few patients who are not enrolled in my study, in those patients, apart from my study, in few patients we have now trying ivabradine as a first line before starting amiodarone. Yes.
Your administration of amiodarone, was it standardized as per the Brisbane protocol, or were you using the bolus followed by infusion? You know what's the Brisbane
Yes,
protocol?
sir. Yes, sir. It is bolus followed by
Multiple boluses.
not multiple boluses. The initial bolus was for a 6 hours time infusion, followed by 18 hours infusion, and then from day 3 onwards we started on divided dose regime.
You didn't have to deviate from this protocol because of hemodynamic issues in any patient?
Sir, one patient developed hypotension after this starting of the initial infusion of 10 mics per kg per minute, and then we had tapered down to the lower dose earlier. But otherwise, we did not require to deviate from the protocol. Thank you.
The next paper is the ultrasonic prediction of weaning failure in children undergoing cardiac surgery. Avneet Singh.
Good morning, everyone. I am Dr. Avneet. I am a cardiac anesthesia fellow from PCSI Chandigarh, and I'm very proud of presenting myself in front of my mentors over here, Dr. Vanshi Mandal. I would like to present my topic for the day, ultrasonic prediction of weaning failure in children undergoing cardiac surgery, a prospective observational study done in our institute. As we all know, cardiac surgery under cardiopulmonary bypass leads to pulmonary endothelial injury and interstitial edema. Surgical handling and ice slush around the heart leads to phrenic nerve injury leading to phrenic nerve palsy or paresis. Interstitial edema and phrenic nerve injury can lead to diaphragmatic dysfunction, in 0.3 to 12% of the patients, which may lead to prolonged mechanical ventilation and weaning failure in 10% of all pediatric cardiac surgery patients. Lung ultrasound is an easy, radiation-free bedside tool with a short learning curve with a low inter-observer variability of 5 to 7%. And in our study, we hypothesized that lung ultrasound score and diaphragmatic function as measured by diaphragm excursion and thickness would be early predictor of weaning failure in our patients. Our primary aim was to correlate the weaning failure defined as reintubation within 48 hours of extubation and ultrasonic assessment of extravascular lung water content and diaphragm function measured as thickness excursion and thickening fraction. And our secondary aims were to assess the other indices relating to weaning failure like PF ratio, rapid shallow breathing index, duration of mechanical ventilation and ICU stay days, and the use of non-invasive ventilation in our patients. It was a prospective observational study, and patients aged more than 1 month to 18 years of age were included in our studies. Those patients who had undergone thoracic surgery, who had dressing at the ultrasound site, and a poor ultrasound window were excluded from the study. The lung ultrasound procedure was the lung ultrasound was done using using a 6 to 13 megahertz linear probe at 3 time points: baseline pre-operative as baseline values during spontaneous breathing trials and 4 hours post-extubation. And an 8 or a 12 quadrant scanning model was used as per the size of the patient. The B lines were quantified according to and given a score of 0, 1, 2, 3 according to the previous criteria given by Gargani et al. For the diaphragm ultrasound, the linear probe was placed at the right and the left subcostal areas at the anterior axillary line, and the probe was directed medially and cranially. The M-mode ultrasound recorded the diaphragm movements. The statistical analysis was done using SPSS version for Windows. Coming to the results, the demographic profiles, we had 50 patients in our study period, and out of that, 7 patients underwent reintubation, and 43 patients were not reintubated. The demographic profile of both the patients were comparable, except for the age, which was significantly lesser as in the reintubation group, and age less than 1.5 years suggested a weaning failure with a sensitivity of 71% and a specificity of 68%, with an area under the curve of 0.74. Coming to the lung ultrasound scores, the lung ultrasound score was significantly higher in the post-operative period from the baseline value in the patients who underwent reintubation. The receiver operating curve analysis showed that the right diaphragm expiratory thickness at the baseline of a value of less than 0.19 centimeter had a sensitivity and specificity of 70% for predicting a mechanical ventilation duration of more than 13 hours. The left diaphragmatic thickening fraction of less than 17.15% had a sensitivity of 85% and a specificity of 49% for predicting weaning failure, with an area under the curve of 0.75 and a p-value of 0.032. Coming to the secondary outcomes, the minimum intraoperative temperature, the bypass time, cross-clamp time, fluid balance at the end of bypass and before extubation, and the rapid shallow breathing index were comparable between the two groups. Patients who underwent reintubation had a longer mechanical ventilation duration and a ICU stay days as compared to those who did not underwent reintubation, and these patients had a significantly higher use of NIV in the post-extubation period. Cantinity and all in this study showed that the age of the patient was inversely related to lung ultrasound score, and the B-line score measured at 12 to 36 hours in the post-operative period predicted the length of mechanical ventilation and ICU stay in pediatric cardiac surgical patients, as we did in our study. The diaphragm thickening fraction of more than 20% at a pressure support of 5 by 5 has been shown to be a successful predictor of weaning success from mechanical ventilation. And similarly, in our study, we had shown a diaphragm thickening fraction value of less than 17%, had an 85% sensitivity of predicting weaning failure. Umbrello et al. In their study had shown that the diaphragm excursion does not correlate well with the respiratory efforts of patients during mechanical ventilation, as we also found a similar result in our study. Our study was limited to the fact that we had a short time course of the study and we did not follow up in the post-extubation period beyond 4 hours in the non-reintubated group. We did not evaluate the concurrent effect of the lung compliance, and we did not evaluate the extravascular lung water or diaphragm dysfunction by other known methods of evaluation. The study can be extended to the to long-term effect, to finding out the long-term effects of bypass and mechanical ventilation on the patient, and also can be extended onto the non-bypass groups. To conclude, the failed weaning patients have a statistically higher lung ultrasound score post-extubation period. Diaphragm thickening fraction of less than 17% during the pressure support period is a predictor of weaning failure, and patients with a baseline right diaphragm thickness of less than 0.19 centimeter can predict a mechanical ventilation duration of more than 13 hours. Thank you.
Very interesting observational study.
Thank you, sir.
How would you characterize diaphragmatic function other than ultrasound?
The diaphragm function can be measured using fluoroscopy and a sniff test. Fluoroscopy is usually done, and serial chest X-ray measurements is usually, in the post-operative period, is usually used to evaluate the diaphragm function.
Okay. Yeah, and if you have a very high percentage of those who are failing the weaning, is there some approach you can think of prospectively that can be tested in a randomized trial?
What we have planned is to bring forward this study into our bring forward a study into the next set of patients, so that during our weaning process we can predict if according to the diaphragm function values, whether they might fail our weaning trial or not. Along with the diaphragm function, the other factors that play into the weaning process, like sedation, the cardiac surgery factors, should also be kept into mind when we are putting the patient in for a weaning trial.
I'm concerned about bias, because the people who are running the ICU are, so this is one limitation in your study, and it's very difficult to blind that bias in your study.
Yes, sir.
And that you have to find a way to overcome.
My study was 90% done by me, 90 to 99% it was done by me, and offline analysis was done by two of my supervisors, Dr. Banashri Mandal and by Dr. G.D. Puri.
Do you think this is enough data to...
This is a very small case study, and a future study of involving more number of patients will be useful, both in the pediatric patient as well as in the adult population. Is required to standardize the values that were obtained in my study.
Do you think this study will make a material difference?
Yes, I do feel that it is a very useful information, because apart from because ultrasound is an insight into what is happening in how is insight into the diaphragm function. Most of the time, our patients fail weaning because of sometimes we don't according to the standard conventional regimes that we use. Apart from that, also our patients fail weaning. So it should be used as a adjuvant in decision making during the weaning process.
Because we already have echo, which is pretty accurate in assessing diaphragmatic function. So how superior is this compared to the
Echo will only evaluate the cardiac functions. The lung ultrasound will evaluate the diaphragm dysfunction that occurs immediately after intubation. Diaphragm dysfunction has been found to be present within 24 to 48 hours of complete mechanical ventilation. So the diaphragm, the serial ultrasound of the diaphragm as well as the lungs will help in evaluating the serial changes in the diaphragm that is present after complete mechanical ventilation and putting the patient on pressure support ventilation. That the pressure support ventilation is known to help the diaphragm in its recovery. So the serial ultrasound during the post-operative period will help in the assessment of the recovery of the diaphragm.
See, the thing is that in the post-operative echocardiogram, this is our protocol to evaluate a diaphragm function.
I think the difference is that you assess the thickness as well as you do a standardized M-mode assessment of the excursion in a standardized way in the right diaphragm, which is different from what the cardiologists do, which is basically a 2D subjective assessment.
What in our institute, the cardiology, our radiographers come and assess for the diaphragm function is that they evaluate the qualitative assessment of the diaphragm movement, whether it is a normal movement of the diaphragm or a paradoxical movement. But my study involves a quantitative assessment of the diaphragm function, both as a diaphragm thickening fraction as well as the diaphragm excursion.
Okay, thank you very much.
Thank you.
So the next presentation is from KDA Institute, Mumbai, and that's novel technique for vascular anastomosis in the neonatal group by Dr. Simran Kundan.
Good morning, ladies and gentlemen. I'd like to thank the organizers for having us present our work at this esteemed forum. So this is a basic design of our study. We evaluate all anastomosis to be done, and we do it by the posterior continuous technique. We start midway from the posterior wall. We turn the corners, and we interrupt the continuous suture by what we call the lateralized any vascular anastomosis. We conceptualize this study for neonatal switches, and we've extrapolated to the Muller's procedure, the Wharton's procedure, the BDGS, and any situation in which we require vascular anastomosis. So in the switch procedure, we do it for the neo-aortic reconstructions. We've done it for the neopulmonary artery reconstructions, and it's especially served us well in situations other than the usual coronaries, where the coronaries are either a looping pattern or a single coronary coming off from either of the sinuses, and it's held us good in that sense. And in all situations, malaligned commissures, where the coronaries go on to any place other than the facing sinuses of the neo-aortic reconstructions. So we are great proponents and fans of the closed arterial procedure propagated by Ed Bovey, and we've applied our modification to this procedure. So to understand the concept of transferring the coronaries onto the neo-aorta, we'd like to bring in the concept of aviation industry, which is the pitch of the movement of the coronaries across the neo-aortic suture line. The roll, which is the torsion of the coronary button along axis, vertical axis along the coronary suture line, and we use trapdoors and bay windows to address the same. And the yaw, which is the viper-like movement of the coronary arteries along the long axis of the coronaries. So we see that usual coronaries follow the simple law of yaw, in which we just have to pull the coronaries after the neo-aorta has been reconstructed. The coronaries have to be turned on to the facing sinus and anastomosed to the facing sinus. But not all coronaries follow this rule. And we've seen that in our practice, coronaries, anything other than the usual coronaries, that is 1 LCX, 2R, in which the pattern is 1L, 2RCX or 2CXR, we see that the right-sided coronaries will come across the neo-aortic suture line. And you see in this situation, the coronary is getting kinked. But in this situation, we pull the coronary up to the neo-aortic suture line, and it's got both the coronaries in a straighter line. Situation in which the left comes off as a single stem, we see that if we put on the left button onto the facing sinus, it's going to get kinked. But if you pull it across to the neo-suture line, it has a much straighter line. In situations in which the left side comes off from the sinus too, we've seen that with the aorta clamped, the situation of the coronary is totally different. And when we've distended the aorta, the coronary has a totally different lie. And even for malaligned situation, this is a child with the tossing being an anomaly, where the coronary, where the neo aorta is massively dilated at the sinuses, and we've plicated a part of the sinus here. But the issue is with the size difference, the commissures are malaligned, and this is where the coronary will come across the neo-aortic suture line. And most of these coronaries will come with a little bit of torsion, and we'll have to get in the bay window concept and the trapdoor concept to fit in the coronaries across the neo-suture line. And this is where the advantage of this technique lies. Once we've closed the posterior wall continuous and the anterior wall is with the interrupted sutures, once the aorta is distended, we don't have to undo the entire suture line to place these coronaries. All we have to do is just cut open the interrupted suture lines and place the coronaries across the suture line and have a much straighter line. We've done it for PA reconstructions. In simple PA reconstructions, we always aim for tissue-to-tissue continuity with the interrupted suture lines to maximize the growth potential of the neopulmonary arteries. And we've done it with complex PA reconstructions as well. And as you can see that with the pulmonary arteries flaccid, it's a different situation. Once the pulmonary arteries have gained their distension, once the clamp is off, the neopulmonary artery suture line is always anteriorly interrupted to maximize the growth potential. So we've done it for Muller's procedures. We see a lot of children with 3+1 pattern where one goes up to the vertical vein, and we've had to put it back to the left atrial appendage. And to maximize that anastomosis, we've done the posterior continuous and anterior interrupted suture line. And these are the anastomosis which are just 5 to 6 millimeters, and it is the situation where you have to maximize the area of the anastomosis. We've done it for the Borden's procedure as well, and the design remains the same. Now, this is a much bigger child. This is a 12-kilo child with not much difference, but where it really scores is a situation in which the child has a bilateral SVC. And as you can see, this SVC is usually small. The right SVC is usually small. And to maximize this anastomosis, this procedure has served us really, really well. And all our glens, we've done it by the same procedure, posterior continuous and anterior suture line. And as you can see, the lie of the glen is truly bidirectional with this situation. So along the other procedures, we've done it for a few situations which we had to transect the aorta to reach the pulmonary arteries and re-anastomose it. And even for a few TAPVCs in which the infracardiac TAPVCs in which we are afraid that the anastomosis is going to be very small, we've done it in the interrupted fashion. So it's served us well. We've not had any problems with the supravalvular distortion, the switches, and no coronary revision, which we all know that coronary revision intra-op is an indication for poorer outcomes. We've had only 9 redos in our 485 cases of PA reconstruction. We've had a gradient of around 1 millimeter in the Mullers. We're averaging a gradient of around 2 millimeters in the Borden, and all the others have been more or less laminar. And this is a proof of the pudding of our procedure. This child was referred to us from outside for a bilateral glen and falling for completion Fontaine. And we can see that the suture line here has got intimal hyperplasia and also on the anterior surface, and the suture has cut through. Whereas in our procedure, this is a child of a DKS who came up for a glen. We can see that the anastomosis has actually grown, and the spaces between the interrupted sutures have actually grown rather than being dilated. So to summarize, it's a very easy procedure. It makes the procedure very, very mathematical. It is a very versatile approach. It can be applied to all situations of coronary anastomosis, of vascular anastomosis. It maximizes sutured lumen without any purse-string effect, and it allows for equal distribution of tension, which in the short term results in less bleeding, and in the long term actual growth of the anastomosis. Thank you.
Carefully compared difference between outcomes on your group technique versus the conventional technique. And have you presented that, or do you have data?
Yes, we have data on that, sir, but we've only had data on that in the switches group because we've always done the interrupted technique. And comparing our cross-clamp times to conventional cross-clamp times, we've seen that even though our cross-clamp times might be 10 minutes longer than the regular cross-clamp times, but in the long term, we save a lot of time achieving hemostasis.
Where is the evidence of that in your presentation?
I don't have evidence of that in our presentation, sir.
Thank you, Simran, for your nice presentation. Tell me, how is your description interrupted sutures for vascular anastomosis?
Vessels as well as anastomosis of vessels to the cardiac structures. And having the posterior suture line continuous, Alexis Carrel was interrupted suture line all along. That takes a lot of cross-clamp time. We've done posterior continuous, which saves us a cross-clamp time, and only the anterior layer is interrupted, and that's where we gain over in the switch procedure.
I think you'll agree that the continuous suture line using proline is not a risk factor for restenosis, and all surgeons would do that. That happens in coarctation repair, that happens in the aortic suture line. I think the only advantage of using interrupted sutures is that you can cut across the suture line without
Follow only the
vascular anastomosis.
yes, sir. So we conceptualize in the switch and we extrapolate it to all other vascular anastomosis.
Thank you.
Thank you.
As the judges finalize the winner for this session, we have some quick announcements. Poster session is being put up in the lobby area next to Dr. Dolly D. Hansen Hall. Poster viewing is present through the day. A luncheon symposium on the topic MFO Advantages and Indication, Meaningful Innovation for Better Clinical Outcome will be held in this auditorium at 1:30 p.m. by LifeTech Scientific. There are some special events alongside the main conference. Shrimai Braveheart Woods Tree Plantation Drive will be held on all 3 days throughout the day. Blissful Heart Yoga sessions by Yogi Ji Mr. Richard Gorel will be held on all days of the conference between 6 to 7 a.m. The venue is the Sacred Space on the first floor in this building. 5-mile run will be held on Sunday, 13th October from 5:30 a.m. to 6:30 a.m. All interested participants are requested to reach the venue by 5:15 a.m. All those interested in these events may please get in touch with our volunteers at the registration counter. Transportation will be arranged to and fro from all designated points. The plenary session will end by 1:30 p.m., after which we break for lunch. The next scientific sessions for the 3 specialties of cardiology, surgery, and anesthesia will take place in this building. Scientific program for cardiology will continue in this auditorium. Scientific program for surgery will take place in Dr. P.K. Sen Hall. Scientific program for anesthesia and intensive care sessions will be held in Dr. Dolly D. Hansen Hall. Our volunteers will guide you to the respective venues. all senior faculty members who have not received their registration kit may please get in touch with volunteers present on to the left side of the hall.
There's only one award to be announced. So I'm making the announcement. We've come to a decision. I think it was unanimous, and the winner is Dr. Arvind Balaji. Give him a big hand. Dr. Nayan Banerjee came very close, but the strength of the study design presumably was much better with the first winner. It was quite a useful, fruitful session for us. Thank you. Okay, presentation has to be by somebody you need to decide. Maybe Dr. Anand, or you can ask one of Dr. Nikaido to give the presentation. Is that, or unless, isn't it?
Requesting,
Can you come on stage?
requesting Dr. Arvind Balaji to please come on stage.
So, Dr. Balaji, it's my great. This, for all the young people in the audience, should be a less entire session has taught us, and as well as so designed like a double-blind randomized.
The session. Next senior faculty is one whom we all have. Ladies and gentlemen, please give a big round of applause to Dr. Hisashi Nikaido. Sir, please.
I would like to make sure, not translocation, how about this? Yeah. Okay. Yep. This one. Good morning. This is an awesome meeting, really. I responded to Dr. Kadewa's kind invitation and I came over here. It is indeed a tremendous honor, privilege that I can talk to you, to this awesome audience. Thank you. This is a simple picture drawn by Frank Netta many years ago. They are going back and talking about many years ago, then this description of transposition goes on all the way back to 1797. And various authors described transposition since then, and then it comes into 20th century. Katsuji Keito, from my mother country, Japan, studied in our Children's Memorial Hospital in early 1900s. And then here he published a paper in 1930. They are compiling all previously described transposition, 92 cases, and added his own 5. I spent quite a bit of time at the Children's Memorial Hospital in Chicago, and then that name will come up later. Maurice Lev essentially defined what the detransposition is all about. They are studying in various ways, and published in 1945 as he was getting out of Army. At the end of Second World War. What he described was indeed the basic understanding of transposition. Here's Maurice Lev, who worked in the Hector N. Institute in Chicago, not too far away from Cook County Hospital. And he used to visit the Children's Memorial Hospital often, at least once a month, and reviewing various congenital heart specimens. And I learned quite a bit from him. Incidence of transposition has been all known, that and indeed comprises about 5% of all congenital heart disease, and the male-female ratio is 2 to 1. Natural history, as described by Cato in 1930, 80% will die by the end of first year. Subsequently, Jerome Liebman in Cleveland presented in 1969, and a little bit more details, natural history. I had a chance of meeting with him in Cleveland while I was taking a thoracic surgery training. This is the New England Infant Cardiac Registry started by Alexander Nadas, and it points out that if the transposition is associated with various other anomalies, then they may have a better survival, especially like a single ventricle or a ventricular septal defect and pulmonary stenosis. And in a way to the right side, you can see if it is a simple, straightforward detransposition, their survival is extremely limited. And the reason why is this simple picture just showing the circulation. The normal circulation is a series, and transposition circulation is a parallel. So unless there is a communication on the both sides, these children will not survive. Alfred Blaylock, the grandfather of cardiac surgery, together with Rollins Hanlon, presented the first successful, or at least attempt, to salvage these children with a transposition in 1950. They tried, of course, Blaylock is the one that started shunt operations. So he tried, and 9 patients in just a shunt, Blaylock Tausig shunt, and then there was no survivor. And then taking Hanlon's advice to making interatrial communication, and then Blaylock-Hanlon operation was tried in 12 patients, 3 survivors. Blalock Hanlon and Blalock thoracic shunt in 12 patients, 8 survivors. Things are getting better. However, in a total of 33 patients, only 11 survived. This is the Blalock Hanlon operation description and going through right thoracotomy, exposing interatrial groove posteriorly, making a parallel incision and removing atrial septum and creating interatrial communication. This is a very difficult operation and extremely high in mortality. This is the end result in an interatrial communication crisscrossing the circulation, thus improving oxygenation. I never had the chance of meeting with Dr. Blalock. He passed away as I finished general surgery training. But yet, Dr. Hanlon, I had multiple connections. He was the examiner for my general surgery, a board meeting, a board certification, and then since then I had multiple interaction. The last time that I requested some photograph of him that he sent me. This right side picture in about 5 years before he passed away. Early trial was done in 1954 by William Mustard in Toronto. He did some coronary artery studies and transpositional hearts, and it is nearly impossible to move both coronary arteries. So he decided at least left coronary artery he's going to move. And he did this on the 7 patients. At that time, the cardiopulmonary bypass was just the beginning, and certainly not small children. It was not available. So he utilized the monkey lungs as oxygenator, and then, of course, not all patients died. In the Chicago, the Children's Memorial Hospital, Thomas Baptist, they presented a paper in 1956. This was the first realistic success of half venous switch operation. Inferior vena cava blood was guided by aortic homograft towards left atrium, and right pulmonary vein was reattached to the right atrium. Thus, essentially half of the systemic venous return will go to the left ventricle and the pulmonary artery to be oxygenated, and half of the pulmonary venous return will go into body circulation. He tried this operation in the 38 patients, 14 losses, but yet the survived patients enjoyed a significant improvement in oxygenation. As a professor, and one was listening, they tried his own approach at the Canton Hospital in Geneva and reported this in 1959. He even tried 3 arterial switch operations, no survivor, and 4 venous switch operations of his own design, well described, and only 1 survivor. But this was the first complete venous switch operation ever performed. This is the picture of the sending operation that he included in his paper. In Toronto, William Mustard continued his trial to take care of the transposition, and reported 1964 his own so-called mustard operation. They are in 7 patients with 5 survival. This ignited significant excitement among the cardiac surgeons, and many tried. They have a mustard operation, including the group at the Children's Memorial Hospital in Chicago, in which I was included. This is the venous switch operation of mustard, creating creating a pericardial tunnel within the atrium, and they are guiding pulmonary venous blood into tricuspid valve and the systemic venous return to the mitral valve. More interesting and exciting, the improvement was made in the management of transposition, reported 1966 by Rashkin and Miller. In this approach, they passed balloon catheter through pudendal valley into left atrium. Balloon gets dilated and pulled back into right atrium, thus creating interatrial communication, improving oxygenation of these infants. My mentors in Children's Memorial Hospital, in the middle is Alexander Muster, and he is the only one alive out of these 3. He used to do balloon atrial septostomy and making diagnosis by cardiac catheterization. On the right side is Milton Paul, who was a real genius in the cardiology. They helped us tremendously. On the left side is Farouk Idris, the chief of cardiac surgery, and my teacher and senior colleague. Later, I would mention that I did leave the Children's Memorial Hospital at the end of 1977. And at that time, I thought that maybe I should look at it, what kind of success that we are creating, especially in the small children, small infants, less than 1. They are 3 days of age, and the majority of the patients about 6 months of age, and the mortality. Amazingly, out of these nearly 30 patients, they are 3 days old and underwent mustard operation, and as she was recovering, this became a newspaper of release, and then this was printed in the South Bend Tribune. September 27, 1975, next to me and the baby, Edgar Neufeld, and it was my close friend and a cardiologist. 20 years later, I received a letter from the mother of this particular patient, and that as she has done well, she's now developing a palpitation. As you can imagine, that this is the major issue with the postoperative venous switch patients. Has taken over William Mustard and a contribution, and already more than 200 cases that they accumulated. Early mortality is only 2%. And then earlier 100 patients is a little bit lower Kaplan-Meier curve, and an upper one is a more recent series of 100 patients for some years. But yeah, this report came out in 1977. This kind of description encouraged the surgeon to think about doing more of a sending operation than mustard. The mustard operation is a little bit too individual attention needed, in contrast to the sending operation. Sending operation is more repeatable. Although these similar pictures were included in Senning's original paper, but somehow we neglected. But it was resurrected at this point, and then today, now it is being used all the time for a double switch operation. And then now we have done 70, so not spectacular, but yet at least we were able to close VSD and do mustard operation. At that time, I decided to go to the pathology lab and picking up all the transposition hearts and locating the VSD, where these VSDs distributes. And they're pretty much the same as most of VSDs with Z. Challenge of the complex mustard operation, and a mustard operation that together with the VSD closure or a pulmonary stenosis, etc. Those patients continue to challenge us tremendously. And this report was 1981 from Detroit Children's Hospital, but this was confirmed with another paper then two years later from Boston. If the patient happens to have ventricular septal defect, that their mortality is significantly higher. Children's Memory of Mustard Operation and additional in 77, we have done 130 out of those patients, and 3 died by various methods, subaortic, subpulmonic resection, success. D4, that is that the baffle obstruction or various venous channel obstructions, this was said to be related to the age at the time of the surgery. Yes, the probably the structures are bigger, probably you can do better operation, but yet you cannot wait long time, such as this group. The lower group is less than 1 year of age. Upper straight line that good results were obtained in children over 1 year of age. And you cannot wait on a transposition babies beyond 1 year of age. It's a very difficult proposition. More of a problem, the venous switch operation, very disappointing and shocking. As you can see on the left side, they have a declining presence of sinus rhythm, and in the middle, the increasing, they have abnormal rhythm. They have, this is the issue as Toronto group explained, and they realized that this may very well be arrhythmia. And in this particular paper, they pointed out the declining, sending up 100 patients in 1999. Yes, and the Kaplan-Meier curve, and you have upper one is a simple, they have ascending, and then lower one is complex. That was reasonably good, we thought, but yet, if you look at ventricular function, right ventricular function continued to decline. If right ventricular function declines, then the only choice would be transplant. That was really a major challenge. And then the group in training ventricular function. As much as Dr. May eventually was totally Baffist. Baffist described this in 1961. As you can see, this is the way today we do arterial switch operation. And he proposed this, but he never had a chance to try on human. 2 patients in his own mode of arterial switch. Since he realized that the 2 coronary arteries may not be able to be moved independently in the small children, so he decided he's going to take a cuff of aortic root and flip over to the posterior great vessel root, and thus the transferring of both coronary arteries. Admittedly, both coronary arteries will be twisted 90 degrees, but yet he thought that that should not disturb coronary blood flow. In these two patients, one survived several hours, the other one survived almost 20 hours, but in two patients he tried, no success. And the others are from São Paulo, Brazil. He tried on two patients, and when he reported, then the first one didn't survive, the second one, 40-day-old patient with a VSD, survived. This was the first survivor of arterial switch operation. I was taking additional surgical training in thoracic surgery in 1975. I did not know this, Jatini's success. As I was leaving the residency, I was given an opportunity to present something that's unique and then interesting. So I presented this hypothetical arterial switch. This can be done. So this is not much different from the previous reports. But yet, then I thought that the length of blood vessel as we move could be a problem. So I went to the angiogram of the transposition patients and then tried to measure these anterior wall, posterior wall length. And then indeed, if you do perform the location of these two vessels, and the posterior wall is significantly shorter. As all of you know, today, arterial switch operation we perform, we almost always place some additional material on the posterior wall of the new pulmonary artery, lengthening or covering this shortage of the blood vessel length. I also went back to the coronary arterial switch operations. I came to different from normal, but yet majority of them could be transferable, and we need to know more about it. First clinical trial that I have done was in 1983. This was 8 years after the first report of Jatini. It took a long time for me to get on this. But yet, I will explain to you a little bit later how difficult to switch from venous switch to arterial switch. Good thing is, 35 years later, this patient showed up to Cook Children's Hospital in Fort Worth with his daughter in his arm. He's doing very well, and it is clear example how successful arterial switch is. On the right side older gentleman is the guy who gave a consent for the surgery. He asked me, have you done anything like this? No. Can you do it on an animal experiment? No. Do you think you can do it? I said, yes. So he signed the paper, and then there he is. Great, contributor. This really helps. Arterial switch operation. Boston Children's reported this. That's with them. He reported 14 cases. So, 50 cases in function is preserved better in if the patient shows up a little bit low pressure, you can pulmonary artery banding on a shunt. It's very difficult. Patient conditions in the ICU, and you cannot extubate them, and really holding the breath and hoping that the left ventricle will generate enough amount of pressure. Yes, left ventricular pressure does go up quite amazingly rapidly. And the majority of these patients, by the time 5-6 days pass by, and their left ventricular pressure is already ready for arterial switch operation. If that is the case, maybe we can do arterial switch operation anyway, and then support them on ECMO until left ventricle will learn what they should be doing. And this report came from New Delhi, the year 2010. This is indeed a remarkable report. And 56 patients they worked on, and they were more than 6 weeks of age. And overall survival is remarkable, 48 out of 55. And then if you set up the cardiopulmonary bypass equipment with ECMO socket, and then if you try that kind of approach, 15 patients of the 12 survivors. And this makes sense that these are blue bars, and over years, bars are unfortunately they are lost. Why do you have to switch to arterial? Indeed, this particular paper written blue bars are mustard, and green bars are sinning, and then red bars are arterial questions. Although theoretically, and then we presume with the multi-center studies, 470 cases, and then as you can, arterial switch operation is done with a VSD closure or other anomalies, either trapdoor or any other mechanisms. Somehow we can send the arterial switch operation, especially arterial switches, from the top curve survival. In this study, they point out the very interesting pulmonary stenosis that we already coarctation. What really we have to pay attention is the aortic insufficiency, and more seriously at the bottom, and 6 coronary artery status is reported from Boston Children's Hospital. The summary is pretty good in comparison to normal. So it is not really true. More recent report in 2017 further detailed the study of intelligence of these postoperative arterial switch patients. There clearly problem exists, but yet they are ordinarily functional, and at present we have to continue to pay attention to more of a neuroprotection during the surgery, but yet is that really related to the surgery or timing of surgery, or has nothing to do with it, and genetic problem somehow, we don't really know yet. Coronary artery was studied in Brazil. Of course, they started arterial switch operations, and so they reported here as early as 2005. If you do look at coronary artery, there is this narrowing at a proximal segment of coronary arteries. And indeed, they and all did well. But interestingly, majority size and so forth, only way you can determine is doing angiogram. You cannot really do angiogram in hundreds, not solved. I now work at Cook Children's Hospital in Fort Worth, Texas. They have my colleague, Dr. Tam, is an excellent, talented surgeon, and he himself, has excellent results in arterial switches. As you can see, many of these patients had even arch repair done at the same time, but yet in the last several years, we didn't see any mortality whatsoever. Obstruction. And those patients, and I will talk about the team or new cardiothoracic surgery when to full professorship, all of you. Every details to share the failures as well. And this is our life. And talking about failures, problems, challenges, questions. We don't know enough. We don't know enough today. So that's why we are struggling. We just cannot come up whatever we want to see. Yes, that is true. This is a God-given opportunity for you to improve. So don't fret about challenges, problems, or questions we cannot answer. Keep on thinking and keep on, yeah, now I know that's where I made a mistake. Maybe that's why they don't try. If you're gonna try, keep on our approach. Be curious, remain curious. That's where something new will come to you and to these children for better life. Ambroise Paré, this quote, Je l'ai pensé du le guérit. I'm not a French scholar, so I hope that I read it right. Ambroise Paré was the barber surgeon who served 4 French kings in the 16th century in the various battlefields. He brought in the horse-drawn cart to pick up wounded soldiers. This was the beginning of ambulance. He ligated the bleeding blood vessels to stop the blood loss. He came up with a new approach, cleaning the wound with clean water and wine, of course, a Frenchman, and dress the wound with clean dressing. Up until that time, bleeding wounds were burned with heated metal plate, and he stopped doing that. That is really wounding the patient more. He recognized, so he washed the wound and cleaned it and dressed it. Somebody asked, how did these patients got healed? His answer was, I dressed the wound, God has healed. We, as a human being, we can do only so much, but yet, up there is a far bigger power of healing, and he is willing to pass that healing to all of us, including our own patient. Thank you very much.
Thank you, sir, for your inspiring talk. I request you to please remain on stage. I invite PCSI Governing Council members on stage. Dr. Snehal Kulkarni, ma'am, President, PCSI. Dr. Rajesh Sharma, sir, Vice President, PCSI.
It was indeed the best history lesson of transposition of great arteries, complete presentation, and I would have the lecture to continue in this service. And we look forward to your own operation, which you have still kept us in.
The next session is about education and training and will include presentations that will focus on the important aspect of capacity building of doctors and nurses. I request respected moderators for the next session, Dr. Anita Saxena, ma'am, Professor of Cardiology, All India Institute of Medical Sciences, New Delhi, Professor Kalongos, Professor of Pediatric Cardiovascular Surgery, KOC University Hospital, Turkey, and Dr. Krishna Kumar sir, Professor and HOD Pediatric Cardiology.
Will I start? Okay. This session is all on training of different facets of pediatric cardiology. So we start with Dr. Suresh Rao. I would say low and middle income countries.
Well, I was bowled over when he gave me this topic, and I hope in the next few minutes I'll try to justify whatever I've been given. Surgical training is like a jigsaw puzzle. You start with basics, and you suddenly one day feel that you are a trained surgeon. So that's in essence surgical training. In the next few minutes, I'll go a little more detail into it. My idea of surgical training is to build a brain-hand connection and feedback between the two. We always talk of the hands of a surgeon, but we forget the fact that it's the brain behind it which guides the hand to do what it does. Yeah, you should have a steady hand, you should have fine motor movements, you should have association, judgment, experience, learning, knowledge, and so on and so forth. Surgery, when we are undergraduates and postgraduates and then on, the first, of course, is keen observation. That's how we observed and took up surgery. Then as you finished your training in surgery, you practiced and you practiced more. And in the course of practice, we started correcting a few of our techniques based on the complications perhaps which we faced. This bred self-confidence into experience, and once you became experienced, you were a little more aggressive, rather on sometimes too aggressive. And finally, that led to what we call as judgment that we have with us today. We all go, and which was indeed a study by training, by graded responsibility. We have other models where next model. Many a time in our course of careers, we have learned, we have self-trained. There is nothing better than a traditional form of guru-sishya relationship, where the end point is a completely trained, but then the end product is most important. What is a guru-shishya relationship? This is amply exemplified in the Hindu mythology of Mahabharata between Dronacharya and Arjuna, who is an extremely skilled person, and Dronacharya is the teacher. It enjoins the student and the teacher in a special kind of relationship. There's mutual respect and admiration with no selfish interests. There's implicit obedience and devotion to learning the skill on part of the trainee. There is no time limit for skill acquisition, but with the only vision of the end point that the person under whom you are training, or the trainee, becomes a skilled person one day. The only gratification for the teacher is a trained and successful student, and the only fulfillment and admiration at the success of the trainee. So when it comes to congenital heart surgery, there are no animal models that we can create or think of. Basically, it is learning, innovations, experimentation, and all this is in the operating room after a lot of thought, debate, and study of various techniques. This branch of surgery requires exceptional surgical skill, exactness, and you need to develop a 3D mindset. More than any other branch, it's an open book for everyone to see, and it is independently evaluated, as most of the surgeons' audience would have known when the cardiologist comes to do the echo. Any change in training of surgeons in the low-income groups? I would emphatically say no, the training of a surgeon is universal. But in limited resource settings and low-income groups, perforce we train on the patient, which is truly the real thing. Fortunately, at least in India and many other developing countries, we are beginning to develop wet labs, which is there in this meeting a couple of days hence. And this has been a recent phenomenon, but it's a welcome change. But generally, it has been martyrs. I think every surgeon in the training has had martyrs. Unfortunately, the training programs in our country lacks committed mentors and role models. I think that is the models, and 3D models are evolving. We have given from the hard models, now we are getting the softer resins, and that's going to mimic the tissues which we are going to handle. Well, I think this might be the future for training, because we can make 3D models of any congenital heart problem, and perhaps this is the way to go in the future. But as yet, it is pretty expensive, not widely available. Now, before we talk of training, we need to say, where does the surgeon train? So we need to have a training center. It has to be a specialized center, meeting the standards by the regulatory bodies, which as yet, we don't truly have a regulatory body to determine which can train congenital heart surgeons and which doesn't. All the allied specialties have to be covered, and most importantly, you require a senior surgical mentor interested in training. There have to be adequate volumes, varieties of cases. There has to be a training schedule which is dictated by the abilities of the trainee, because I don't think 2 years or 3 years, a finite time period, is enough to train a particular, to train the surgeon. Now coming to the trainee person, after all the credentials are met, there has to be reasonable basic skills and knowledge of the subject. Motivation, enthusiasm to learn, and receptive to suggestions, criticism, immediate senior surgeon, but by the whole team. There has to be a progress year on year, which is visible for everyone. There has to be an ability to accept errors, introspect on it, and dependent. There's no room to think when you're learning. Now, coming to operative training, there has to be a grasp of the subject and concepts. And you have to convert these to practical application. There's no point in having sense, because many a time, this is what really bails you out. In the process, as you train, you develop a sixth sense, practice, and in the process of building up confidence from the mentor. Ability won't be progressing further in life. Now, coming to a few points, how do I train my juniors? My training begins with quizzing the candidate at various situations, CAT meetings, ICU rounds, on-the-table discussions, process, and preparedness when they come up for a case. Attention to detail in interactions with the team, including draping. Anticipate this if possible, and prepare for it much ahead. Most important thing, I would say, is ability to live up to the confidence imposed by the mentor, and transgressing the line will be reviewed very, very unfavorably. And this channel of communication is most important between the mentor and the mentee. Now, coming to the practical aspects of training of the surgeon, competency in doing a good sternotomy first. Thymic dissection, there's no point in having a mass there which is bleeding when you're coming to do the surgery. So the trainee has to pass this test before he goes one more. This has gone in placing the purse strings. Cannulation, closure, and at a more senior level, decision-making to keep the sternum open or closed. Coming to the starting of cases of a training of a surgeon, VSD. If a person can close a VSD very well, in all situations, you move on to tetology, right ventricular outflow resections, Glenn shunt with wall replacements, and above all, good suturing techniques and knots. You can't have bad suturing, and you can't progress further without getting this technique right. Now coming to the neonatal surgeries, which you, as a congenital heart surgeon, has to do. What I have been doing is, again, they have to show proficiency in sternotomy, in thymectomy, purse strings in neonates, cannulation in neonates, extremely important. Many of the my junior surgeons have stopped short of this. They have not progressed further. Great artery transection and coronary markings, where you are going to put the coronaries and transect the great arteries. PDA dissections. Pulmonary artery reconstruction perhaps is the one full thing they start off with. Coronary harvesting thereafter. Neo-aortic reconstructions. Then finally is the full arterial switch when you transect the great arteries and go ahead. And thereafter hemostasis, decision to close primarily or delete sternal closures will have to be thought about. Now coming to some of the training scenes all across the world, this is from a publication, Pediatric Cardiac Surgery Annual. If you can see more or less, it's between 10 to 12 years after you finish your undergraduate training, where you have various times you have spent in general surgery, in pediatrics, in pediatric surgery in some of the Latin American countries. But by and large, after your cardiothoracic training, it is around 2 to 3 years of congenital heart surgery training. But on the right side, if you see the United States, where you have two streams, that's a traditional stream and the I6 stream, even after their 1 year of mandatory congenital heart surgery fellowship, they're called upon to spend at least 1 to 2 years as junior faculty, not from the American Board of Thoracic Surgery, but from the candidates who have gone through it. They wish to spend this much time as a junior faculty. So to answer the question in this survey of 40 trainee surgeons, how long did it take you to be able to comfortably manage most congenital heart surgery issues with competence and complete independence? If I can see there is nearly, most of them, it's between 2 to 5 years. So it does take, even after your fellowship, around this much time for you to be an independent surgeon. How important do you think is a senior mentorship in the first years of clinical practice? 85% felt it is extremely important. So therefore, in the course of training, after you finish your fellowship, there is a period when you continue to be mentored by a senior surgeon. This is a very interesting survey which was done. And if you see on the right side of that is 5+ years, you find most of the surgeons become independent. So it does take around an average of 5 years for complete independence without supervision by the senior surgeons. So to wrap up, training of a congenital heart surgeon is complex and depends on a lot of variables. It can be trainee variables, trainer variables, center variables, and a number of cases, volume. Great investment on time on part of the trainee and the trainer is required. And there are responsibilities enjoined on both the parties. It's not just one, it's not that it takes two hands to clap. The mentor should be committed to train, give surgical opportunities to the younger colleagues, and should be confident of handling complications if it is created by the junior surgeons. And the younger colleague is not another pair of hands. That's an important recognition which I think the mentors have to understand when they hire a junior person. On part of the trainee, they should aim and take pride in becoming his or her mentor's trusted colleague. I think that should be the aim for the junior surgeons at the end of their training. And it should be imparted in the current scenario with no change in surgical outcome. That's mentors' huge responsibility to see that the overall outcomes are not compromised in the course of training. I would like to read this out for your information, which was published in this book, Walk on Water, by Michael Rudman way back in 1983. The pediatric heart surgeon had to have it all: the intellect and the skill, the grace and the decisiveness, the sewing skill, because the longer a kid was on bypass, the longer a baby's circulation was completely shut down, the harder recovery would be, and the more danger there was of what was euphemistically called neurological deficit. There was no other surgery in which precision. So, ladies and gentlemen, this is what as a surgeon, you need to achieve and at this level. And finally, I'm a surgeon, but it takes long to become a safe and a skilled cardiac surgeon. Thank you very much.
Thank you, Dr. Rao. I think we'll have a little discussion in the end.
We will continue. Yeah, thank you very much, Dr. Rao. Very good presentation, and I believe that the training depends on the training center, especially the volume of cases you offer to the young surgeons is very important, and the second one is the quality of the mentorship. Now we will move on the second presentation entitled My Vision of a Comprehensive Pediatric Cardiologist, presented by Dr. Ranghavan Subramanian.
Since, just for the sake of the audience, Dr. Raghavan Subramaniam is a, for those who don't know, is there an introduction which comes by? Anyway, I think I will give the introduction. He is a very senior pediatric cardiologist currently at Frontier Lifeline Hospital, but has been a mentor and a trainer and an inspiring person for many of us in this auditorium.
Respected chairpersons and friends, a very good morning to all of you. A few months ago, Ashish called me and asked me whether to accept it, even a little apprehensive. However, as I started working on this talk, I realized I was actually appraising my... There are other slides which made me quite uncomfortable. Makes my job easier. All the points, or many of the points that he has said in a surgeon's training probably apply to the cardiologist, and I do not intend to repeat them here. We need dedicated and comprehensive pediatric cardiologists, and we need lots of them if we want to even solve a fraction of all these issues in our country. What is comprehensive? Different dictionaries, more simpler ones. Complete, that's simple to understand, in-depth, thorough. But the ones I liked was everything that is needed or wanted, or everything that is necessary. So if you know what is necessary, what is needed, and if you know who needs it, it should be pretty easy to be comprehensive. This oath is well known to all of you. It's attributed to Hippocrates, although we're not sure whether he actually wrote it. It was been deciphered from an ancient Greek papyrus. And many of these points remain as valid today as it was at his period. Respect your teachers, respect your colleagues, and respect your patient. Give knowledge and receive knowledge. Be willing to learn. Provide the best possible treatment. If there's somebody who can do a procedure better than me, it's a must that I must refer my patient to him. And of course, I must treat everything in confidence. Over the years, this oath has changed. And this oath probably represents the first attempt to lay down a code of conduct for physicians. The points which were added later on emphasize the importance of prevention, the protection of environment and the planet. But I would particularly draw your attention to the fact that it recognizes the disease and related issues. It recognizes the fact that the patient can be affected not only by the direct effects of the disease, but a whole lot of other things can go wrong with his life. And it is the job of the treating physician to address all those issues as well. That's what would be included in the word comprehensive. Therefore, the oath and the usual understanding of comprehensive indicates that qualities are idealistic. But we live in a modern world, and there are many more requirements added onto that, and these depend upon the perspective of our patients. The patients are also changing with time. our colleagues, our employers, and many others around us. What does the patient want? No marks for identifying what he wants. Everybody knows this. He wants a quick relief and, if possible, cure. He wants them with minimal pain, discomfort, no complications, no side effects, at minimal or no cost. He wants to grow up and lead a normal life, wants to be productive. He doesn't want to have any repeat procedures. And finally, he wants two more attributes from you, which is empathy and respect. These are a little more difficult to quantify, and often we do not pay attention to that. He wants to be known as Master Kumar rather than that kid with the ventricular septal defect. He wants his privacy to be respected. He wants his time to be respected. And he wants his emotions to be respected. So, he has his own set of requirements. But there are other people in the field. The doctor has his own set of requirements and ambitions. Obviously, he wants to be known as the most successful practitioner. He wants to be highly skilled. He wants recognition in society in any form it's come. He wants to earn money, and he wants to have a decent, balanced life. If these were the only two players in the field, life would be easy. But it's not to be. There are many more stakeholders in this subject, and they all exert pressure on the doctor's time and energy. You have academic pressures. Everybody wants a training program, trainees. You have to produce papers. You have to attend meetings. The more projects you have, the better cardiologists you are considered. The hospital, they're interested in numbers and profits, publicity at any cost, and all this without spending much money. The family wants you to earn money, and possibly because of this, they also want you to remain healthy. They want a good slice of your time, quality time, without your phones, without your laptops, and without calls from the hospital. And of course, there's endless documentation from the quality department, parameters, audits, reviews, and all of this put together is a circle of demand on the doctor. And mind you, this is an incomplete list. I haven't even listed the people management, the finance and budget management, the complaints, the VIPs, there are many more people who demand the doctor's time, and therefore it's all one person. You need a superhuman to be able to satisfy all this and score high in each one of these fields. There may be a few super cardiologists who are able to do that and score 100 out of 100 in all these fields. But I am not one of them, and I don't think most of us are. Most of us are just ordinary, normal human beings. And therefore, there are many days when I don't feel like the angel or demigod. More often than not, I feel like a tired, exhausted person. The pressures are relentless. It's like being inside a giant crimping machine. The day I keep my patient happy, he wants to be cured and he wants his bills to be waived. If I do that, the billing section and the administrator calls me and says, this will be deducted from your salary. If I prolong my cath meeting and discuss a case with my students, my quality department tells me my door to consultation time has crossed the critical limits. Therefore, there is no end to it. You cannot keep all these people happy all the time. Something had to be done. Therefore, in this scientific era, they tell us that you can reduce practically everything to numbers and to a mathematical equation. So that's what I did. Generally, we agree that patient is the center of our universe. Therefore, I made a weighted pie diagram telling myself which is more important, which is less important. And obviously, the patient took the giant share, 5 out of 10. The total score was 10. The doctor, myself, came next, and then all others were scored 3 out of 10. This would give me an idea how much of my time, how much of my energy should I spend on each aspect, to also provide me a system by which I could evaluate myself as to how I am doing. This slide made me very uncomfortable. It gives you the impression that these are all isolated islands, when in truth they are not. They're all highly interdependent. If I have a patient who is happy, the hospital gets more patients. If I have a quality control and I give better service to my patient, you have better publicity, and therefore your numbers go up. The patient is more happy. In truth, all these areas actually overlap, and it would be wise to concentrate all our efforts and all our energy on that middle area where there is considerable overlap among all your activities with the welfare of the patient. It's absolutely not necessary to be an outlier. In other words, you don't have to be a #1 cardiologist in your city or in your country to provide good. You do not have to have the maximum number of procedures to accredit or the highest number of publications. If you concentrate on the central area where you're overlapping about 50 to 60% of the area, believe me, you can do a lot of good to yourself and to your society. A list of all the qualities attributes, and 13,000 people responded, and finally the blog writers analyzed them and brought out the top 30 terms which were used by the layman to describe an ideal doctor. Please note that almost all those terms relate to the personal qualities of the doctor, and there are very few terms related to his professional capacity. The patient don't want the fastest surgeon. He doesn't want the cardiologist who has done the maximum number of stents. He wants a human. He wants a person who is compassionate and has all these characteristics. The only few terms which related to his professional capacity was logical. He should know his limitations. He should know what he knows. He should know what he doesn't know. And he should be thirsty for knowledge. That's easy. But most of the other terms in this 30 did not relate to his training, did not relate to his professional skills. People's perception matters if you want to be a comprehensive doctor. People who have traveled to Egypt must have seen the step pyramids. Even about 5,000 years ago, they didn't have cement, they didn't have even steel. They built tall pyramids. They realized they could build tall pyramids only if you have a supporting basement. The basement has to be strong, it has to be broad. Also, when some of the old step pyramids were evacuated, there were some smaller pyramids inside. That means they built pyramids on top of other pyramids. Why is this important to us? You should look upon your career as a pyramid if you are to be comprehensive. The base is very important. The base comes very early in your life, possibly in your childhood. Values, quote unquote, good doctor can only make in life, and you need to have a genuine interest in people, a genuine interest in your neighbors. But cardiology is not enough. You need to know a little bit of your allied subjects, the anatomy, the physiology of systems, a basic working knowledge of all the disciplines around you. If you are already a trained pediatric cardiologist, you must know a bit of echocardiography or electrophysiology. Your patient needs them, and therefore you must have a working knowledge of all the subjects in your discipline. You may be extra trained, extra specialized in one area, and how to seek that help. All those things come in your first initial years of training, and Dr. Suresh Rao's talk is very apt for this. You need to train, you need to get trained, and you need to seek help later on in life whenever necessary. You could go higher on in your career, you could get advanced training in a very, very specialized field. You need to do research and publish papers, but the papers have to be relevant to the society in which you live in. It should mean something. It should produce some obvious benefit to your society. And obviously you need to develop managerial skills. You need to manage people, you need to manage students, the training program, and so on. And you need to manage your management, the hospital managements. That's the most difficult task. You could grow higher, and the only term I can think of is maturity. Maturity is a term used to describe how you put to use all these other skills. The efficient, appropriate, and the timely use of all the other skills that you have learned throughout your life reflects your maturity, and that is what is important. I have symbolically left the top of the pyramid as a flat top. Sharp points in your personal or professional character do not help anybody. It does not help you. It does not help your trainees. You cannot be a good trainer if you have sharp points. The higher you go in terms of specialization, there is a risk of becoming very narrow-minded. You could lose touch with ground realities, and that's important to touch base with the ground now and then and reinforce the bottom two rungs in this pyramid. There are many tasks that you cannot do alone. For example, if I am a pediatric cardiologist, I know something about a ventilator, but I cannot wean a patient off the machine. I do not know enough about cardiopulmonary bypass. Arrhythmia is a specialized subject by itself, so I need other specialists. And therefore, it is a team which makes you comprehensive. You need a pyramid built on other pyramids to become a truly tall and broad team. You could provide a good service to the society by extending its pyramid laterally. You could also pass it on to other doctors and build top pyramids of future generation. Therefore, you eventually build an edifice as long-lasting as the Egyptian pyramids. And ladies and gentlemen, I hope all of you have met this new competitor. His name is Dr. Artificial Intelligence. He claims that anything you can do, or I can do, or even all these senior professors can do, he can do better. And therefore, are we endangered? Yes. But there's one thing this artificial intelligence cannot do, and that is to provide the human touch. Remember, if you lose your human touch, you'll be replaced by artificial intelligence, and that's one more reason for you to become comprehensive and stay comprehensive. Therefore, in summary, ladies and gentlemen, comprehensive pediatric cardiology care, or for that matter, any physician's care, is all about building long-term relationship. Long-term is particularly important in pediatric cardiology. The patient comes to you as a neonate, and he stays with you all his life as an adult congenital heart disease patient. Even at the age of 65 years, he comes back to you for his treatment and advice. We have to build up a long-term relation with our patients over time. One cannot be perfect. Now, that statement, I feel very good when I say that. One cannot be perfect. You have to find your own goals. Find your goals which is flexible, which is practical, which can be done by you. But the only condition is it has to be patient-centric. You have to imbibe this culture of comprehensiveness, nurture it. It matters where and with whom you train. You pick up many of the qualities of your mentor. If your mentor was comprehensive, you probably have better chances of being comprehensive. Therefore, it matters where you learn, where you train. But once you imbibe it, nurture it, and spread this culture to your colleagues, spread it to your trainees. Obviously, self-appraisal is important, and this talk was one example where I appraised myself. And probably the most essential thing to be comprehensive is to build or at least join a great team. Thank you very much for your attention.
It's going to be hard to follow this talk. But Bistra, you have the not so envious task, but I'm sure you'll live up to it. So Bistra is from Children's Cardiac Care in the country, and we share a 20-year-old relationship with her, both from an institutional perspective as well as from a country perspective.
Thank you for the introduction, and thank you for the opportunity to speak. Having heard the previous two speakers, actually, I shouldn't be giving this talk because I'm not a nurse, in my perspective. I was asked to talk about training with what we know in the West, where I live. First, just to start with, is that the 200th anniversary of, as a nurse, she did a lot of firsts, even though she wasn't actually called Nursing Now. So we'll be eager. Some of the statistics that they have cited initially before publishing is this very serious global shortage that's predicted by 20. Most affected are going to be South Asia and Africa, which India falls in that category. It's predominantly a female profession, so 70 how it's been promoted or not promoted. This compares to 41%. Here, evidence, mostly from the and expertise, actually decrease in patient mortality. There are several studies that have been published. Dr. Patricia Hickey from Boston Children's Hospital has been a very prominent nursing educator and nursing education supporter, and she's been part of studies. This first paper that came in 2013, where they actually linked directly the experience and the expertise of pediatric cardiac intensive care nurses to lower mortality in the cardiac ICU. Similar paper was actually produced for cardiology nurses, and there's also a paper that I don't have listed here that talks about OR nurses. Children's Heartling's experience as an organization that has supported nursing education over the years. One thing that I can talk about is we developed an upskilling program at Red Cross Children's Hospital, which is a hospital in Cape Town, South Africa. And we were able, through that program, to actually affect nursing turnover. So we had a decreased nursing turnover and actually doubling of ICU beds. I guess we're having technical difficulties again. So is nursing different in India? Some would say maybe. Maybe in certain ways it is different, and others it is not. We know that it's a big problem. Migration is a big problem, and retention of nurses for hospitals. Every hospital that I've spoken with or I visited, with actually the help of lower socioeconomic background. Education is becoming more. In addition to that, there's not very good standards in terms of nursing. There's complete lack of career progression. It is very stressful. It is, in my opinion, the hardest job of all for nurses. They stay with very often and often leave the country, as we know, of new staff. So so what can we do? Actually, these three strategies of what we try to do when we enter a team, I think that's a very important step. Prove the clinical competency, I think there are two places where that can be done. One is in the nursing colleges, and probably this audience is not going to be necessarily involved in that, but in hospitals, that's where we actually train specialist nurses. So implementing structured in-service nursing training programs would be a very important thing and someone can do. And another piece of that is actually developing nurse educator positions. And I still put that it needs to be a paid position. And most often than not, it needs to be a full-time position. So what are some of the components of a good nursing training programs? Nursing training program, there has to be an adequate bedside training. There has to be continued mentorship from more senior nurses and physicians as well. Nurses need to have incentives and pathways for career progression, and they need to have opportunities for continuing education. Unfortunately, a lot of those things are lacking in many programs, and I would say that India is not an exception. This is the case in many different countries. I just came from the Philippines, where they actually are the biggest exporter of nurses around the world, and it's a very similar problem there as well. There are resources, though, available to develop those programs. Many of you here probably are familiar with the International Quality Improvement Collaborative, which has a lot of training resources for nursing and other staff. And Open Pediatrics is another free resource based in the United States, also where nurses and actually physicians as well. This educator role should look like. So they have the curriculum in collaboration and monitoring evaluation framework of what are the requirements. Experience that they're suggesting for developed what we called nurse educators and teaches theory and practical skills, education skills, and bedside clinical support. And when we implement board, the hospital just did not see the value of that program, and as a human resources resource versus just a disciplinary team, I think that's something that we need to continue as a community to do, and to respect the profession. There's definitely need for improvement of collaboration with physicians and other hospital staff. Nurses also need safe and stable work environment, which means that they shouldn't be taking care of 5 very complex patients, but when we have in the ICU really high acuity patients, that probably ratio should be 1-to-1. And I've often seen sometimes nurses just being moved around a hospital, different departments. This is a specialized profession for a very specialized and complex type of patient. And just like these patients need specialized surgeons and specialized cardiologists, they also need specialized intensive care nurses. So that's something that often hospital administrators do not understand very well. And again, they need to be paid better. There is one way to promote nurses as key members of the multidisciplinary team, as I said earlier, is develop nurse educator roles. We've tried, actually, developed a parent education tools and for nurses to get more engaged with family in terms of family education programs, and also develop nurses as quality improvement leaders to lead improvement changes, just like Florence Nightingale did when she was working in 200 years ago, 150 years ago. Developing nursing leaders, I think that's, again, a collective effort. The 6th year at Children's Heartland started the nursing track at this conference. The abstract submitted, and maybe close to 800 nurses attending this meeting. This is 800 new people and 100 new abstracts and work submitted, improvement work submitted in pediatric cardiac care. And I think that's incredible and shows that there's a lot of interest. What I've seen a lot and very often is that nurses do not have resources to attend the meeting, even though they really want to come. They don't have resources to attend the meeting. So I'd really encourage the society to continue supporting the track and to continue developing it. So what does the future hold? I think we all need to continue supporting and elevating the profession through professional development. The next step is really development of advanced nursing roles, and I know that there's several of those that either are in process or have been developed already in India. They need to be paid better. Nurses need to be included in leadership roles. Often in the United States, for example, nurses are in leadership position, administrative leadership position of the heart center, along with physicians that they work with. So they really need to have equal standing with the rest of the team. And I throw in technology tools because I think we're all talking about technology, but there is actually opportunities for technology that can be used for better decision making. I actually tend to be an optimist about artificial intelligence. I think it will make decisions much better and easier for physicians and will make the work easier rather than harder. So I'll just finish again with Florence Nightingale and this chart, because she, when she served in the Crimean War, she was called the lady with the lamp because she was checking in on all the soldiers. But she did something amazing. She actually decided that, and she wrote these amazing reports. And these are some of the first charts that would like to, some people call her actually the lady with the pie chart, and I actually like to call.
Thanks very much. By Dr. Parvati Iyer, who is the director at the Fortis Heart Institute, Delhi, of Pediatric Care Specialist.
This is to move up, and not on this. Okay. Om Sai Ram. I am I'm going to speak organized I have is, as you all can all probably see, I have a very bad cold and a viral, so I request forbearance if I need to interrupt my talk. So the outline of my talk is intensive care unit. Do we need specific other LMICs or low middle income countries? And what has been the career path of those whom we have trained over the last 25 years or so? And can we try and retain some of those we train in pediatric cardiac intensive care? And what are the challenges? And what are the challenges that we face? Where do we go from there? And to conclude, do we really need separate pediatric cardiac intensive care physicians at all? For the purpose of this talk, I have been told by the organizers to try and stick to pediatricians and other physicians. So I will really not be touching upon how we train our intensive care nurses or other extenders like nurses and nurse aides who in our unit form major key drivers in decision making and are an important part of our multidisciplinary team. To those of whom who don't know us, I'm from the Fortis Escorts Heart Institute in New Delhi. We've had, as an organization, a checkered history, but to go way back in 1988, this was set up as a 350-bedded cardiac center. The pediatric program had its inception in 1995, and we've been doing about 650 to 700 surgeries per year. The point to note is only half of those patients pay the costs which are incurred, and about 15% pay. Currently, we are a 15-bedded dedicated pediatric cardiac intensive care unit with 1 senior surgeon, 1 intensivist, 1.5 anesthetists, and 2 cardiologists. When I say 1.5 anesthetists, it means during his free time, he also covers global data and innumerable publications, a plethora industrialized world. There is strong C-level of evidence, and today's paper published in Pediatrics and emphasis on having a dedicated counterparts were a little later to start off with. So there really has been a paper from Kerala, from Amrita, which has shown. So what's the status? Dedicated pediatric, they are innumerable, along with essential elements for sustained pediatric intensive care. Various factors that we all know, the specific attributes and dictate the need for pediatric cardiac, not just by teaching and training, but by an ongoing to people around the world. There's a grid entry into the UK. We trained a couple of residents and various procedure acquisition. Like this, how to start and sustain and find our own solutions. What did we do? Onwards, we've had an in-house on call, that means who stay within the in the very first week that they join the unit. Some of them get the average time, clear care plans for each patient. We have protocol pathways, which are training in skill development, particularly procedural skills. Not that we do not have adverse events, we have our own share. Shed the philosophy of hyposcalia, which you will find is a rapidly editorial written in the Texas Heart Journal by Herbert Fred, who was the professor of medicine at Baylor College. To learn extraordinary vigilance in a busy unit to try and performance, we need to have synchronized team performance to ensure good resuscitation, and above all, to try people to have resilience and staying power, especially in our parts of the world. When you're caught in between scenarios, extreme diligence and focus needed about a year to 18 months. For the average clinician who had no exposure and not in our unit, and our philosophy is like to acknowledge the organizers because it has taken me on a lovely, memorable have been through our unit. 16 of them had just passed their MBBS and had spent a year or year and B. Now, out of these 73, the point to note is that or worked for less than 6 months extremely half-heartedly. 43 out of the 73 worked who were extremely committed and passionate, and who left after telling me before they joined itself that they were. Of interest is that only 1 out of the 16 interns left at all without notice. So we found our MBBS 43 of them who did any kind of consolidated training with us pursue it still. This includes pediatric cardiac intensive care, isolated pediatric intensive care, some units with some cardiac or remunerative subspecialty, and move towards pediatric cardiology, which is fine. But these are some facts which we, our country, and the other half move to greener pastures. Now, this is really a tribute to some of the new pediatric cardiac programs within our country. I need to show this slide basically as a tribute to this young man, 50 surgeries with very little help, and they have the most fantastic outcomes ever. This young lady is the earliest trainees that we had is a very fine intensivist. Excuse me. Decided to completely to give up cardiac intensive care, and today he's consultant and rotating head in the pediatric intensive. Been putting my talk together, and I asked them all, why are skilled and trained physicians like you all reluctant to perceive that there's a lot of stress and burnout? Not one of them mentioned stress and burnout as a reason to abandon cardiac intensive care unit. One actually used the word that it's boring. Somebody else found it frustrating, and much more so when they went to feeling trapped and insecure, or he's likely to get good organizational history, cardiac intensivist. A number of them at least go out and see cardiac patients, do talent retention. If you look at Forbes and skilled employees, there's a lot of give equal importance to an intense news for professional growth, which was mentioned by a career path for yourself. And many agonized, many of them like and love till 2015 on of months. And many call as well as to train them and help them build a career. Twice what anomalies and contradictions in published literature across the world. Staffing and work, and now the BMJ. Heart surgery units will stay who are suddenly displaced overnight due to no fault. So I will not allude to any institutions, but I think everybody's pediatric cardiac intensive care foresee a very our own state level, but across the country, and to writing out their thesis and passing their examination. Though what about anesthetists? They said they cannot. We felt they were the highest stakeholders. Intensivists did all the work and to run the intensive care unit. They said on days, and we are focusing on skill development as intensive care that we've ever had the privilege to encounter and train. So when you look at our 24-year mortality, 15 onwards, when the surgical unit actually mans the intensive care unit, we all work together. I can't really say that I guide the impact of intensive care unit attendings, educational and training background on outcomes and the various intensive care units. And this is in the United States, mind you. Some of them were cardiologists, some were anesthetists, some were mixed bags, some come. So to conclude, ladies and gentlemen, and have them in the intensive care unit. But what we can talk about is we need to have our own trade special skill sets, but it's easy to evolve them. You need to have your own fast-track training module different in every single country in the Shenzhen area. Retailing talent has many, many voices, because if you don't hear your voices, you will be just barking up the wrong tree. In the meantime, till we have sustainable and viable pediatric cardiac programs, and you have to have your own alternative manpower pool, whether to have successful outcomes. Thank you very much.
I would really ask if Dr. Kalangos or Dr. K.
Educational and training aspects in pediatric heart surgery, especially for a sustainable and especially in the intensive care unit for the intensive care. For this, the most important, especially around the child.
Our future, especially
I think one partner that we save care in times to come, because pediatricians.
I thank the moderator. We all know that pediatric cardiac care is a resource or foundations that conduct such treatment programs in the underserved. In the interest of time, I request all speakers to please complete their talks. In speakers for the next session, Dr. Sean Shetty, Medical Director of Pediatric Hearts and Souls, to please take their seats on the stage.
clinical nurse, and so we're all looking forward to her talk today.
It's wonderful to be back in your lovely country, and I'm really happy to be working again with the Sanjeevani. So my talk today is Healing Hearts from Cameron, my second job, which is volunteering on cardiac. In these environments, you get to work with some of the most amazing. To date, I've done over 60 missions to the countries presented me with an Order of Australia, which of course is lovely, and whilst recognition is lovely. So my dad, who's a minister, and my mum, a teacher. Growing up, I loved to read, work in Africa. His books captured my imagination with vivid descriptions of operating to performing his rituals by moonlight, only to run foul of the local thorn bush and having to abandon his moonlight. I loved his stories and got lost in these for hours. One day when I was a baby nurse on the ward, this is a photo taken of us that was used for the hospital I loved to be. And in 1994, I was asked to fill a last-minute position to go to the pediatric programs, both with OHI and more recently with St. Ultimately, it's for these little faces, whether you get to live or not. The resources and the skills to help them, and it's our opportunity to give back. Firstly, you have to love what you do, because when you do that, it doesn't really feel. To perform relatively complex surgery, fun while we're doing it. Volunteers who I've worked with in the past have now become regular offenders like myself. Capacity, resourceful, ingenious, and very inventive for the perfusionist to see the surgery when you can use a rear view mirror from a car and attach it to an IV. Lifelong friendships both with the local teams and with the members of the travelling team from the Pol Pot regime, in which all their professionals and medical population were either killed en masse or had able to help their own people. We have a very healthy sense of competition with our PNG team. That we have a game called State of Origin between Australia, Sydney and Brisbane, and we like to join in that to do the cases as safely as possible. Thirdly, you need to love a good faced by the local teams are usually limited resources and therefore the need to reuse and reprocess consumables. The other challenge is usually the state of the hospital. Its roof leaks when it rains, so we have to move the patient to the side so that the water doesn't come onto the, and lately an electrical testing program as well. And this is in a creative way that the Goroka-based hospital tried to encourage funds around the hospital, so promote it with this stamp. Secure up until only a few years ago. I think I posed a bigger risk trying to learn to shoot an arrow in the village there. Where possible to open the chest instead, and it actually worked quite well. Our surgeon in New Guinea has a little pouch on her there. Visiting medical staff become the patient. That's a picture of Ian who had some kidney stones and needed some pain relief. And then there's the other challenges of challenging, interesting and random cases that just turn up while you're there. This picture of a little PNG boy who was out hunting in the village, got a bird arrow that went through his shoulder, missed his heart, missed his lungs and lodged in the top of his liver. So he had to travel for 2 days, first in a canoe and then in a plane and a car, neither of which he'd ever been in or seen before, to arrive at the hospital. Then we had to use a saw to cut off the end of the arrow and pull it out through his abdomen. And we remember that the local surgeons deal with these kinds of cases all the time. So the 3 different types of trips that we usually go on are suited towards whatever the country's need is at the time, and that can change over time as well. So service trips, we bring all the required consumables with us, and the emphasis is on doing as many cases as safely possible. Therefore, we do all the cases and the local team assist where they can. And in PNG, we started as purely a service trip, and so we would work 3 theatres and approximately 70 cases in around 10 days. Then there's the educational teaching trips to already established services. So in there's trips to Vietnam, Mongolia, India. We bring very few consumables and the emphasis is on skill transfer and ideas exchange. We work alongside the local team and make suggestions as requested by them, and we learn as much from them as they do from us. Then there's education trips to assist establishing a service. So we take very little consumables and we encourage the local team to source their own. which is a lot cheaper for them usually anyhow. Emphasis on education and establishing an ongoing sustainable program. Success is to have the local team operating unassisted, as was happening there in Cambodia. So it's not all work, and it's one of the best ways to travel, because you get to work with the local staff and you have a greater understanding of their country than a regular tourist would. So you get to sample some local cuisine and some of the local brew if you wish, a bit of local fashion and hairstyle, and support a local economy by going shopping at the markets. And then there's the opportunity to travel before or afterwards. Here I got to walk up the side of the volcano in Vanuatu. Attend a highland sing-sing in PNG, where all the tribes come together and perform traditional dances. Visit some of the most remote villages in PNG and walk the Kokoda track in PNG. Visit the Shwedagon in Myanmar. Sorry. And relax in tropical paradise. And these are sentiments that are echoed by many other volunteers from developed countries. We have some of them come back and visit us on following trips, which is really nice. We get to work with truly amazing and gifted people and get to challenge ourselves and our skills. After meeting Dr. Ashish in Cambodia, I've had the pleasure of working with him and his Sanjeevani team both in India and on surgery missions in Fiji. And from these experiences, I've observed that although countries like Australia can help with resources, skilled and trained staff, there are extremely valuable contributions that teams like Sanjeevani can make to these programs, especially for developing countries wanting to start their own program or their own service. Here you have the perfect place to train staff in an appropriate and relevant environment, doing appropriate case or types of cases and high volume. You also are able to provide an example of how to run an affordable and sustainable service using and reusing resources in a sustainable way, which is also relevant to their environment. For the future, I'm looking forward to working with our Indian/Australian/American/any other country we'd like to add team in Fiji, which is a winning combination, and working towards establishing a paediatric cardiac service in the Pacific that can help look after all of the Pacific Islands. Thank you for inviting me, and thank you for listening. Thank you.
Thank the organizing committee for giving me this pediatric cardiac issues. So my topic today is to discuss something about the demands, what we have to settle them, and what is the reality we are dealing. So I thank all my surgical colleagues from all over India for giving me information for a survey, no financial conflicts. So the issues I will be touching is the global burden and Indian burden of CST, current Indian scenario, what to do for good pediatric cardiac programs and the challenges for them. The global burden, about 8 to 12 children out of every 1,000 live births have CST, and we are forgetting the diseases of children in the developing countries like rheumatic fever, so they are an extra burden to this problem. Indian scenario is same as the global burden, but here the birth rate are very high, so we get more children in comparison to other parts of the world. On an average, about 2 lakh children are born every year with congenital heart diseases, out of which about 50 to 60,000 need surgery or procedure for survival in the first year of life. This is an article from Saxena Madam. The global annual congenital heart disease mortality is about children need emergency surgery in the first month of life. So an interesting article from LeBlanc, though it's a little old, it's a very funny scenario. India has about 180,000 children who have congenital heart disease in 1 year, and in 2009 used to operate about 6,500. In China, though the population is more, all complications were fixing that year itself. So currently India is the global capital of congenital heart disease, as Ashish says. As per Government of India registry, congenital heart disease has climbed from 4th spot to 2nd spot because other diseases are settled a little better now. So what we need to tackle this situation? Early and proper diagnosis, we need all the resources in terms of medical professional who can do it, society's awareness and screening programs. We need target-oriented approach. So pediatric cardiac programs can deliver the best care, but if they are not available, hospitals which can offer pediatric cardiac surgery should do it. We need infrastructure, funds, manpower. We need to follow these children. What happens to them after surgery? What is their post follow-up management? Do they get interstage care? And we need to catch them early. So antenatal screening is very important. So the best way probably is the pediatric cardiac program approach. I have not written the most important thing that should be in the top is the fund management. The fund is the first thing to manage any pediatric cardiac program. We need all the wings, all the medical professionals, medical and paramedical professionals for this program, and supportive management, that is more important. This is an interesting cartoon from a business magazine which says you need vision, skill, incentive, resources and action plan, everything together to settle any complex problem. Same thing applies to our problem also. Lot of challenges in India, rapid population growth because of high birth rates. We don't have adequate healthcare funding. Competing priorities are there. We can do malaria treatment, more children will be saved. So government will be spending more money for that. We don't have sufficient and adequate equipped infrastructure. Our infrastructure demand is very high. In the same ICU, we will have a 1.8 kilo baby and a 60 kilo child, both are under pediatric category. So one will need a titanium clamp, other will need an adult retractor. So the infrastructure investment is really full spectrum, and we don't have trained professionals. The need of the time is motivation, manpower, machinery and money. So this article is from Dr. Krishna Kumar, as he favorably says, divide India into two parts, left and right. Everything is on the western side, on eastern side nothing more is there, nothing is there for the children. So this is Dr. Sachin Talwar's research, last year he did it. All the centers are on the, most of them are the southern side of India, all the centers are in the cities. And volume of cases, if you see, lot of centers, most of the centers have something between 300 to 600 cases or less than 300 cases. Very few high volume centers. Most of the units do mixed work. Pure pediatric units are very less in number, and most of them are in private sector, public sectors and charitable hospitals are less in India. So we need all sectors in India to do the pediatric cardiac surgery to deal this burden. Public, private, charitable, free treatment hospital, the overseas medical treatment, the funding should be from all sources. Self-funding is very difficult for dealing more number of complex heart disease. We need government support, either national or state government. We need more NGOs in the picture, local NGO or national NGO. Philanthropic organizations are already doing, local charitable trusts. One thing we have not focused is corporate social responsibility, CSR. Today, one of my colleagues, Srinivasan from Genesis Foundation, he was telling Government of India can allot up to 15,000 crores rupees for treatment or any kind of social activity, and we are doing only 1/10 of it, we are not using it. So which system is the best? We don't have the answer. We have all platforms in India. Government system have their challenges, their positive sides. Private system, they have been the mainstay of the treatment. They have got their own challenges. Charitable trust hospital are coming into picture. Again, they have their issues. Free hospital, they are good for poor people. They have got their own issues. Surgical safari is no longer seen in India. Usually, we are going for a reverse safari. We are going to other places and operating there now. Most important is that if we survive, we can give a good care. So what is the important thing for survival? We need to give good outcomes. Standard of care should be maintained because patients are our best ambassadors. The faith among the local people is most important thing. As Dr. Suresh Rao sir was telling, we have to train the next generation. Otherwise, all this technique dies with us. We forget one thing. We need a good administrative support for developing any program. All bill must be cleared. Whoever pays it doesn't matter. unit must not be making any kind of loss. There should be 10% profit at least to beat the inflation. We need to motivate the skilled manpower and keep motivating them to work in a lower salary, because with all the support structure, salary structures is going to be very low. We need a very good working environment for people to work with us. And we must work as one team rather than multiple teams in the same hospital. Manpower is very important. This is an old article. J. Terence Davis from Ohio did a manpower study analysis. What is the requirement of pediatric cardiac surgery in a society? In his opinion, one center is needed for 50 lakh population, and the center should have good number of staffing, more than one surgeon, anesthetist, intensivist, and anesthesiologist and cardiologist. What is the Indian situation at present? We have currently about 75 centers. These are approximate numbers from personal communication. We need about 500 centers to deal our problem. If we operate 400 to 500 surgeries in every center. Pediatric cardiac surgeons, about 120 they operate, 70 do exclusive, 50 do mixed. We need 1,000. Pediatric cardiologists about 200, 100 exclusive, 100 mixed. We need 2,000. Anesthetist, intensivist, we have 100 each, we need 1,000 each. Perfusionist about 130, we need 1,000. Nurses, we don't have any data available, but at least 20 to 25,000 are needed to deal this kind of manpower. Indian scenario is improving. At present, we have about 23 to 25,000 heart surgeries performed in the last year, about 25,000 catheter interventions, about 50 pediatric cardiac centers. I am not counting the numbers which say we also do pediatric. These are the people who do pediatric surgeries on regular basis. We have about 120 senior surgeons, about 200 senior cardiologists. At one time, we have only 4 and 5 ECMO units. Now we have more than 40 ECMO units in India, 5 pediatric transplants unit, and 10 units who are ready to take no-root surgeries on regular basis. Now, what are the fates? We cannot take as single coin. There are two sides: simple congenital heart diseases and complex ones. Simple ones are done everywhere now, especially RAC score 1 and 2. Adult units do have a major role in settling all the simple issues, but the complex heart disease go to a more program-oriented unit, because they are very sick babies. They come in ventilated conditions, septic, organs will be failing on ionotropes. Families are run out of finance as well as interest. Some of the family members will be wanting the child to die. Now, something works in India is theory of natural as well as artificial selection. Those who are in metro cities, they get the care more than those who are in remote areas like Northeast. There is non-uniform distribution of centers, non-uniform distribution of funding. Government scheme rates are very pathetic for complex cases. They reach to a large section of the society, but rates are really pathetic for complex cases. And lot of partial pediatric centers are there. Probably something is better than nothing. There happens something called a rule of filtration. There is pulling of sick patients, terminally ill, septic, neonates, funds crunch patients were left in ambulances in search of a destination center, because people will not be interested to take this kind of surgeries. The kids, when they need the highest level of care and the micromanagement, they will be roaming around searching for a center. Most of them die. Actually, it takes a lot of motivation to operate these kind of patients. Big challenge is the fund management. Complex cases, very difficult to get. Relatively easy funding for simpler cases. And most important thing is midnight, 2 o'clock, obstructed TAPPC ventilated baby comes. What will you do? The fund is most important thing. I did a small survey by personal communication to most of my surgical colleagues in India. The aim of the survey was to know what happens in India and what is the current scenario in most of the centers and what the challenges they are facing. About 54 centers I could communicate. Either a surgeon, if I could not contact a surgeon, a cardiologist or intensivist. If not anybody, a nearby center who can give some information. Most of them are located in metro cities. 31 out of 54 are in metro cities, and 38 out of 54 are in private sectors. So this is an interesting thing. Total number of cases in these centers are about 27,000. And in public hospitals and Sathya model hospitals, about 33% patients are being operated. And about mean of 50% patients are less than 1 year, infants and neonates. Another thing is, though the RAC score of about 39% in these centers being operated, mortality ranged from 1.5 to 10%, mean of 4%, which is not bad seeing the spectrum of surgeries we do. Most of the surgeries were either done under government scheme or supported by trusts or NGOs, and self-funding was seen about 9% of patients. About mean of 4% patients were inoperable as per my surgical colleagues, but that is the tip of iceberg because most of the non-operable patients don't come to us. And I asked about the challenges, what I got. The commonest challenge by each unit is sepsis. About 70% units are facing the challenge of sepsis. And second important is retaining the nursing staff. Because our nurses in India are paid very miserably, they search for better options and move out. The moment they're trained and ready to take care of the child, they get a better offer and go out. Third thing was fund management and procuring a trained manpower other than nurses, about 50% cases. And very interesting things were there. Late presentation about 10%, non-representative admission, that's an interesting thing. Some of the units in well-developed programs, we don't get any simple cases. So that's not a true picture of the general problem. So what we need for the robust pediatric cardiac program? We need to start a program. Most important, we need more and more programs in India. We need a motivation to develop into the next level. What we need is a team approach. All people in the same unit as one team. We need seniors' advice and guidance for doing more and more such kind of work. We need mentors. As Suresh Rao sir was telling in the morning, we need mentors. We have to twin the programs, one big program, good program, with an emerging program, with exchange of manpower and support. So we need spark plugs to help us developing new units. Multitasking, as Parvati Madam was telling, we need multitasking of the members. One person doing one job other than his own job. This helps, especially in the newly forming units. Training of the younger generations is more important. India is the new destination for training of young generation. So can we benefit from the shortcoming of the developed world? We have we fulfill the rule, 10,000 hour rule. We have more working experience. Probably we can do better job and people can come to India to learn. Medical safaris, we don't have more views of medical safaris now. And other than the congenital, I'll take 1 more minute. Interesting questions always come into mind. Should we do Norwood in a resource crunch position? Should we do heart transplants? 6 daughters, 7th one is a son with a complex heart disease. Family is crying and sent. In 1 month, you will have viral pneumonitis and come to the casualty as limited areas. Though we do a survey, what should we do for syndromic kids? What should we do for large families having multiple care cover for complex surgeries? At present, it's really disappointing to see the government submitted in India, especially for transplantation. We can have zonal referral and transfer. We need to standardize the care for improving the outcome. Most important is the aware society to help. Communication is the key. Lot of WhatsApp groups at national level and local levels are helping course in within few hours. It helps a lot in future to improve our outcomes. Thank you very much for the time and attention.
Thank you, Dr. Panda. We'll continue on since we're running late. At this point, I'd like to invite
Good afternoon, ladies and gentlemen. I start by showing you a short film about the birth of Aishwarya Trust. We lost Aishwarya on the 3rd of May, 1991. She was only 3 years old and she was beautiful. She died of congenital heart defect. We did everything we could to save her, but it was not to be. She loved music and she loved to dance. I think God gave her to me for a reason that has eluded me for a long time. It took me 20 years to be ready and able to tell the story. With the right treatment at the right time to play, I had lost. Friend, I decided Aishwarya Trust still lives on every moment. Aishwarya Trust is the brainchild of Dr. K.R. Balakrishnan, Director Cardiac Sciences, who is the co-founder and trust of Aishwarya Trust. In February 2008, Dr. Balakrishnan, during a casual conversation, mentioned how they were unable to help thousands of children get heart treatment due to lack of funds, and asked me whether we could do something to raise funds to help to make the treatment accessible to the parents. When I heard this, something in me just felt that yes, this is my calling and I have to do it. This tragedy and pain it caused us made me want to help create a future in which no family should experience what mine had experienced. And I feel that no child should be lost just because their parents cannot afford the treatment. We were blessed to have the means to support the surgery of my Aishwarya, but my heart goes out to the parents of children born with CHD who did not have the resources to funding an NGO. So I went to my father, Mr. K. Nagarajan, who is a retired finance director of an MNC, and he readily agreed, and he remains the founder and backbone of Aishwarya Trust. We registered 80 is the funds. I went to a lot of people how difficult it is to even start, let alone sustain such an effort. However, I was determined and I felt I have to try my best. And even if I manage to save a few lives, it will be absolutely worth it. So I started with a humble sum of rupees 11,001 from my art business, and then went literally begging for funds. My parents, my family and friends were the first ones to come forward, and we slowly started our work with it. Many times my doctors would ask me for funding for a particular child, and we wouldn't have the funds, but I would ask them to go ahead with the surgery in the faith that we will gather the funds. And miraculously, from somewhere, the funds would gather because of the divine hand above us. Of course, our biggest motivators and pillars of Aishwarya Trust are our team of doctors who work selflessly day and night, putting aside everything, making huge sacrifices in their personal lives to save children. It's their dedicated work that motivates us to work harder and to support their fantastic work, even in a small way. In our first year, Aishwarya Trust supported 50 children with congenital heart disease. And I'm very happy to tell you that in the year 2018, we were able to support 502 children. I'm proud to share that to date, we have given new lease of life to 3,500 plus counting CHD-affected children from needy families, and to 76 children and young adults through the heart transplant program. We not only fund the surgeries, but run a comprehensive program of screening, diagnosis, treatment, and review. After the initial struggle in the first 4 years, we slowly started attracting bigger corporates who were looking for good programs to support as part of their mandatory CSR program. Our sincere hard work and the fact that we work closely with the Tamil Nadu state government schemes brought us more goodwill and support. We have had the support of more than 50 generous corporate donors, and 30 of them are currently active. We have treated children from 14 countries so far. All of them were from families who had no means to fund the surgeries. Apart from India, they were from Bangladesh, Pakistan, Iraq, Iran, Kazakhstan, Russia, Kenya, Burundi, Rwanda, Uganda, Sudan, Nigeria, and Sri Lanka. We conduct 144 camps annually in Tamil Nadu and screen around 12,000 children each year. Between the year 2014 and 19, we have funded 79 heart transplants on children and young adults, making India among the top pediatric heart transplant centers in the world. A little known fact. Kudos to the doctors, nurses, and medical staff. Although I am on the podium, I would like to emphasize that it takes a village to accomplish this. My heartfelt thanks to all those who form this village, starting from my family, my eminent team of doctors, auditors, advisors, patrons, and scores of volunteers who have selflessly contributed in different ways. Without their collective support, none of this would have been possible. Without each one of them who have been involved with Aishwarya Trust have been here because they care and they want to be here. The trust journey continues and there is plenty more to be done to bring relief and smile on the faces of the needy families and their children. United by this passion, let us march ahead, rededicate ourselves to spreading this urgent message. I would deeply appreciate your spreading the awareness of CHD that is treatable and with early detection and timely treatment. It will be a great help if you can look at our Facebook and our website and volunteer in any way. And of course, all donations are welcome. We believe that the promise inside these children is far greater than the poverty around them. When I lost Aishwarya, some people told me that this was for a reason. I couldn't understand what the reason was, losing your child, but now I can see that perhaps I lost Aishwarya so that I could help save many thousands of Aishwaryas in all the faces of the 3,500 children, and she lives in them. Thank you for listening to my story. Do join us in our movement to help fight congenital heart defect in children. Nandri Vanakkam.
Thank you, Ms. Chitra. The next up at the university from Palo Alto, California. Welcome, Dr. Sunny. He will be speaking on prolonging life or prolonging misery, where to draw the line.
Good afternoon. So I'm armed with the knowledge that this talk stands between, or I stand between you and lunch. And so I will go as fast as I can. Full tools at our disposal. So what are the 5 leading causes of life or misery? And then, to my personal bias is to love life and abhor misery. So this is a claim to fame from about 25 years ago, where we published the first randomized control trial of children having high-dose opiate anesthesia. And what we found was, we could decrease the mortality from about 25% to 0 in our experimental group, and that resulted in dropping mortality rates probably after. But this trial was conducted on the prevalent views of medicine and science. I'm going to turn all of that upside down, okay? So hang on to your seat belts, because what we have built today is outdated. We are living on the legacy of Pasteur, Koch, Lister, and others, where we've developed powerful drugs and vaccines. We have great specialties. We have, tremendous expertise, and we have evidence-based practices. But this is built on the framework that the human body it's a reductionist framework. The human body is made up of organ systems, organs, lobes, segments, subunits, tissues, cells. Cells are made up of organelles. Organelles are controlled by proteins. Proteins are controlled by messenger RNA. Messenger RNA by genes. Genes by DNA exons. Exons by the DNA introns. Then what controls the introns? Okay, so how do we have health? This is completely flawed as far as I'm concerned. So this was based on the notion that there is one cause and one disease, one germ and one problem that humanity is dealing with. Now we have chronic non-communicable diseases. They are multifactorial. They affect so many organs. They are polygenic. They have lifestyle issues, socioeconomic issues. Can you tell me the preventive strategy for 200 years of racial discrimination, suffering, and disabilities, mental health issues, dysfunctional families, etc.? That is what we are dealing with today. And the old model of medicine, biomedical science, really does not apply anymore. We are beings. We are human beings. Our being is pure awareness. Within that pure awareness, we develop some beliefs. We develop some beliefs. Those beliefs drive our thoughts and emotions. Our thoughts and emotions drive how we perceive the world. A hostile person lives in a hostile universe. A loving person lives in a very loving universe. And that's how, what shapes our microRNAs. The microRNAs drive the competitive endogenous RNA network, which then drives the DNA in a healthy body. So this is focused today from illness to wellness. Can we, instead of talking about pathogenesis, let's talk about salutogenesis. How do we support, enhance the beauty and the diversity of life that we are dealing with? So rather than fighting the causes of death, we need to enhance the cause of life. Once Mother Teresa was approached and they wanted her to participate in a rally against war. The India-China war was going on at that time. And she said, no, when you have a rally for peace, I'll come and join you. But I will not put my energy for a rally against war because it enhances war. So that's what I'm trying to promote. Life is for living and giving. Death is for faking and taking. How do we talk about the leading causes of death and the leading causes of life? Well, I don't need to say much about leading causes of death. There's every epidemiological article, published from Global Health to talks about what are the leading causes of death. For 200 years, we've focused on this list, and we've tried to get rid of this list somehow, and it's still there. So, and it goes on and on and on. Okay, so how do we get to what is life? Now, I'm not going to give the lecture that your dad gave you 20 years ago. My son, this is life. Okay, no. From a scientific point of view, life is a complex adaptive system comprised of individual agents with freedoms to act in partially or totally unpredictable ways. And our actions are all interconnected, interdependent, with each action changing the context for the others. So that is, at least from my point of view, a scientific view. So then, human agency, intergenerativity, and hope always finds a way. And if you want to look at the definitions, you can go to this website. It's called leading-causes.com. Basically, coherence is the way we make sense of life, how life makes sense to us, how we interpret our life as not wholly random or victim to inexplicable forces. Connectivity is our connection of complex social relationships. Human agency is our will and resourcefulness to act, using all the creative freedoms that we have, the full force of our being as a human being. Intergenerativity is the nurturing and affirmations of those who came before us, and then hope You know, hope is not just crass optimism or wishful thinking. Hope is our ability, which is typically human, our ability to imagine a better, healthier, more equitable future, and then to use our human agency to bring that into reality, into existence. So these have their basis. I'm going to quickly go through each of these 5 leading causes of life. By keys was maybe the tools for thriving, but actually coherence is the underlying cause. Connectivity, we are all connected. It's not only applies from neurobiology to the social sciences, but also telecommunication networks. And so the network theory is now being applied to both the natural, the electronics, the social sciences, how connectivity works, what works and why it works. But you cannot live or exist in a vacuum. Human agency is the most powerful force on this planet. This is our ability to change our reality, our inner reality and our outer reality. And so it's not the placebo effect, you know, it's the basis for motivation, initiative, inspired action, which is going to be required if we're going to ask people to make lifestyle changes in order to eliminate those non-communicable NCDs. And then intergenerativity. You know, generations have come before us. They left some nurturing affirmations. They left a historical, existential, and symbolic legacy, which now allows us to be who we are. It's a key contributor to family traditions, to food habits, to health behaviors or cultural receptivity. It's mediated through many mechanisms, not only biomedical, but also social. And then, like I said, hope. You know, one of the first proponents of hope was Ernst Bloch, who wrote this book called Principle of Hope. You know, he was a German philosopher who moved to the US in 1938 when the war broke out. He couldn't stand Hitler. And then he immigrated back to East Germany after the war. But because his views were opposed to those of the government, the book was not published until 1954. Finally, when I was a student at Boston, MIT Press came out with the English version, and it's a mind-blowing book on the principle of hope. So it is what energizes anticipatory action, which is powerful. In fact, a study was done. I'll give one study. There have been 20 others, similar studies. About 750 adolescents were asked, how much hope do they have? And then 4 years later, when they were in high school, the degree of hope predicted less alcohol, healthier food choices, less tobacco use, more physical activity, and in later life, they had less depression. So hope is a very powerful thing. What people are restoring by bringing families to hospitals where treatment is free is they're restoring hope. They're helping explain, this is not, the gods are not angry, it's just simply that your child was born. They're bringing some coherence into those families' life. So, and several others have talked about it. You know, hope is linked to individual and collective action within the web of life. So all of these put together, you know, are the underlying causes of life. When you enhance one of these 5 causes, all the others get strengthened as well. And we've done this on an experimental basis. I don't have the time to talk to you about, but I have good data to show that when you just increase the level of hope, or when you provide just some coherence to the experiences people are having in a community, it completely changes their ability to thrive and do well for themselves. I'm going to skip these next few things. These were experiences I had with Magdi Yaqub and Aldo. No, that's not it. Misery is a state. Violence against kids, exploitation of all sorts. Between these positive interaction and homes with abundance and, you know, good families. So, Folletti showed that alcoholism, drug abuse, marker of supportive, socially affiliative experiences in young children. This is an article we wrote 2 years ago. We have described for the first time a syndrome of CNS dysregulation in children who have experienced multiple adverse experiences in their early childhood. So that brings us to the other causes of misery. In the last decade, 1.5 million children killed, 4 million disabled. And Jan Tinbergen, who was the Nobel laureate in economics, said the only war worth fighting is the war against poverty. And how do we do that? The fight against poverty demands a new economic ethic, the economics of unselfishness. This is where each one of us has to make a choice. Are we going to continue living our lives self-centered, or are we going to do something to change the lives of others, to share what we have received? So I'll close with a quote from my Bhagwan, my Swami. He says, "No activity can give you the joy that service does. You should yearn for the chance to console, comfort, encourage, heal. See yourself as another, feel his joy to be yours, his sorrow to be yours." This is from a commentary that we published about 10 years ago. So I'm going to skip to the last slide to answer the question. As cardiac surgeons and anesthesiologists and cardiologists, I beg to submit all of human life is sacred and beautiful and pure, that all our opportunities for patient care must be approached with reverence and love. Evidence-based medicine will tell us what to do, but how are we going to do it? What is our state of mind when we interact with the patients? That is as important as what we're about to do. In my practice, when I come into a patient's room, I bow reverentially to that being. These are not children, these are the garments of God. God is within these, and he's giving us an opportunity to be of service. So when we think about life-prolonging surgeries and therapies, what is our underlying intent? Is it to earn more money or become famous? Or is it truly patient-centered and family-oriented? Are we prolonging, what is the burden of pain and suffering on that individual? Are we just prolonging life and its enjoyment, or prolonging the process of death and dying? What will be the impact on the family and on our limited resources? I had this patient, I skipped this slide, but I'll tell you. Patient had hypoxic ischemic encephalopathy, 7 days on the ventilator, not recovering. The dad came to me and said, "Dr. Anand, if you cannot add life to my son's days, don't add days to his life." And that is really important. So I leave you with that message. If you cannot add life and the enjoyment of life to a child's days, don't just add more days to his or her life. Thank you very much.
Thank you. No, I was actually kidding.
So we have one last but not the least session before lunch, which is a panel discussion with the theme Patient and Parent Experience, the patient holders involved. I now invite Bistra Zelva, Vice President, Children's Heart Link. Please take yours. Ms. Trishala Pal, student pursuing her graduation in an adolescent adult patient who has been treated for congenital heart disease and will be expressing her voice from the patient's perspective. Dr. Ashish Malhotra, cardiologist whose child has been treated for congenital heart disease. Dr. Shivani Gajpal, consultant anesthetist at Sri Sathya Sai Sanjeevani Hospital, Raipur. And Ms. Chitra Vishwanathan, parent who has dealt with loss positively and runs a trust to fund surgeries for congenital heart disease.
Thank you. Please take your seats. So we initially had this to keep it shorter, as I think just heard, about the humanity of you. We could quickly make some introductions.
Cardiologist in 1997.
To a congenital heart defect in 19.
I'm the patient. So, how did the experience that you had?
The experience was the pediatrician. My mother, she's not a doctor. She said that she sees that the chain said everything is okay. Again, call the pediatrician. He said, and I said, okay. I said it's a very emotional experience for me. Gives me a shock. Parents. So I think how much is the shock to the parents when they have first the diagnosis made and how heart disease. That time I have a lot more patients and I have a lot more disease which is compared baby to government institute and a very, very incisive and difficult on the dotted line that patient may not make it, but you do your best. So that way it helped me to how the cardiologist can explain what are the risks, what are the consequences, what are the lives. So in this way, looking it from the other side, overall it made me more humble and a better person.
You're now helping thousands of kids that you serve probably are intimidated about interacting.
So when we were dealing with my own daughter's heart problem, she was diagnosed when she was 40 days old, and we showed her to quite a few senior doctors all over India. And one particular doctor, I don't want to mention the name, was very casual when he told us the diagnosis. He said, your child has a very complex heart problem. And, that was the first we were hearing about this, and my world came crashing down. And on the side, he was joking with his juniors and nurses, and he said, so we said, Doc, what do you think is the just put us off, and I was very deeply affected by that. And starting from there, I feel a doctor needs to have like a team of doctors who actually draw the heart and explain to the parents what is the problem, where exactly is the problem, and before counseling them for surgery. And once the surgery is over, again we have how can you call them, like a counselor who can talk to them, because the doctors are so busy, you can't expect them to be explaining every little thing. But there has to be somebody who, and we have from Aishwarya Trust, we are very conscious of the fact that the children's parents need to be in the picture, and they need to be told the truth in an empathetic way, rather than just telling them facts which bring them crashing down. So we are very particular about that. And I must say that my daughter had her second surgery in London, and even there, though the doctors are competent, etc., there was when things went wrong. I was with my daughter in the ICU for 2 months after her surgery, and one after the other, there were complications, things were not working okay. At that time, none of the doctors actually came and spent any time with us. And they always told us that if you want, we'll arrange for a sociologist or a social counselor who will come. And luckily for us, we had gone on an assignment there for 2 years, and we had my husband's colleagues who took it upon themselves, and every single day they would come and sit with us and gave us the counseling that was necessary. So to answer you in brief, I feel it is a very big part of the pediatric cardiac program, that first of all, the doctors, when they diagnose the problem, should do it with an empathy, and later, we really need people to work on this and be empathetic and explain things to the parents as they go along.
actually have a follow-up question. So with the physician teams that you're working, have you implemented any specific programs with them where, or have you?
It is given in our, even in our group of doctors are quite uneducated. We are catering to the underprivileged community, and sometimes we need somebody who can explain.
So there is a way. So we don't have much time, just one more question for...
I want to say a few lines because it is time constraint. Yes, I do believe that people face difficulty while encounter doctors in their life. And I myself a doctor, but I encounter doctors in my life when after finishing my fellowship program, when I joined here with them, there is an interest, not like no barrier between time. I started talking with them. Even I try to understand them because yes, empathy and emotions is very important. And yes, emotion always lies behind the work of the doctor. So very difficult to change overnight. So one who is embedded with the emotions will feel the joy, not only pediatric, anywhere when he is working with any of the patient. That nature, that empathy, that sympathy will come on spontaneously. And then he or she starts talking with them sooner or later and very friendly. So it's like an inborn thing. It's like an inborn thing, and it is not with the medical people, it is with the non-medical people. So it just need to be nurtured. Yeah.
So my last question is for Trishala. If you could tell us a little bit about your story and what has been your experience, and then to finish, what is one thing that you want, one message that you want to give to physicians and to nurses who treat children or treated children like you?
Yes, I agree with the Dr. Shivani that the environment of this hospital was too good. The doctors and the nurses are treating us like we are like a family here. If we are staying for 10 days or 5 days or 8 days, so we are like a family. The doctors, the nurses, the staff members, everyone are very kind of nature. They are serving like as a good thing. So as the Dr. Shivani has said, the environment was to give us the God, Sathya is living here. It's true. If any other hospitals we go and see the environment, it was not too good. I'm from Varanasi. I said about the BHU, it's not too good services are provided. I said that. When I come here, I have got and I have recovered in only 5 days. And that was too very, very happy thing for me that it was being provided for me and able to understand what was the problem, what my parents wants to do, they can't understand. Just everyone said about the institution here, they bring me here and just operate. The doctors are very cooperative, so they just are being recovered and I'm just fine. My surgery was done on 12th November 2018 and on 12 November 2019 it completed 1 year. So it's very thank for giving me a new life to the Sanjeevani. So thank you, ma'am.
Just with a couple of comments that with all of our panelists here, they talked about exactly the same thing. Compare difficult clinical environment, having to take care of a lot of different aspects of the disease, but it's equally
We shall now break for lunch. Lunch is served in the space behind the auditorium.